Good morning. Good to see you. Thank you for being here. It is the 3rd of April. We meet as the NHS University Hospitals Liverpool Group Board of Directors. I have apologies for today's meeting from Heather Barnett, Chief People Officer. Welcome to PIP. Tracy Ellery, Non-Executive Director. Siobhan Sue Ray, Non-Executive Director. Daniel, Corporate Affairs. Holly covering Daniel's role today. Sarah Walker, Non-Executive Director. A number of people to welcome to the meeting. Diane, Director of Nursing at Liverpool Women's, been with us before, joined today by Stuart, Medical Director from the team. Welcome, Chris. Welcome to members of the public. Jim, there's an introduction you want to make.
Thank you, Chair. May I introduce Dr. Malala Ranjipaksha. Malala is a leadership fellow from the Sri Lankan government's Department of Health. Malala is with us for a year in the Chief Medical Officer's office. This is an arrangement which the Sri Lankan Department of Health used to enable their senior medical leaders to get experience internationally. And in a lot of hospital management and leadership is undertaken by doctors. It's a slightly different structure, and there's a professional development program for doctors in Sri Lanka. So it's an opportunity for us to explain our system and make comparisons between our system and that in Sri Lanka, and indeed for us to learn from Malala about different arrangements. For example, immunisation rates in Sri Lanka are much higher than they are in England, including for medical workforce. So there are very interesting things that we can learn from each other about how we work. So Malala will be with us throughout the year.
Excellent. Thank you. Welcome, Malala. And a declaration of interest.
Yes, thank you, Chairman. I thought I should update my declaration of interest. I've been asked to do a financial governance review for an NHS Foundation Trust in the Northwest. From what I understand, there are no material contracts between that trust and LUFT, or the Liverpool adult youth specialist providers. I'm hoping the work will be completed later this month, but I thought I should make the board aware of that piece of work.
Thanks, David. Good. Right, let's look at the minutes of our last meeting that was on the 6th of March. Any points anyone wishes to raise on the minutes that we won't cover later on the end of this one? Okay. Can we approve the minutes as a record of our discussion? Yeah, thank you very much. We've got the action tracker. Holly, can you help me with the action tracker, please?
So there are two outstanding actions at the moment, one in relation to providing an updated patient story on organ donation, and then also an update on patients with no criteria to reside as requested at the last board. Both of them are scheduled for the May meeting.
Okay, thank you very much. Let's not notified of any urgent matter arising, so let's move straight into the Chief Executive report.
Thank you, Chair. So today, just a few things to highlight, and I just wanted to take the opportunity to give a bit of a brief really about where we've ended the year, because of course today we are reporting on March in some instances and earlier in others, because how the data gets finalised, so you might be able to see the March position on urgent care and cancer yet in its entirety, but I'll give you some of the headlines. So in terms of the report, just wanted to draw out a few things. Firstly, I referenced the Liverpool Women's Awards ceremony, which is detailed in the paper. I won't go through all the details, just to say a fantastic event, but particularly a real honour for me to be able to present an award to Zora Castling's parents and husband. Zora was a well-regarded and well-loved colleague at Liverpool Women's who died and was celebrated on the night, which was a particularly touching moment. So it was a fantastic evening, lots of money raised, and fantastic for staff who all got nominated for awards. Lots of great winners, and Jenny hosted excellently, and it was all went very, very well. So very pleased to be able to report that back. Staff survey results, it's in the paper today, and we're going to talk about it later, so I won't go into lots of detail. But as we've said there, I think it's a reasonable position in that we've sort of held across the group performance that have been improving for the last year or two, which is good, but still a long way to go, as we know, and a really challenging year. So I think in the context of the challenges we've had in financial position and the control of some of the Griffin control measures, I don't think it's a bad result. So for that, we look forward to then trying to build on that in the years ahead. So we're going to hear later about how we do that. We've talked about EPR before, and we're actually out now to procurement. So since the last board meeting, the procurement started on the 18th of March. So we'll now have a preferred EPR supplier for the electronic patient record. We'll obviously then roll out across the future, which is great. The last case for change is really now gathering pace. That was approved at the ICB board last week, and is in the papers for us to discuss today. So again, I won't go into too much detail on that, but obviously, if you think about the context of where things are nationally at the moment, that's a really important part of making sure that as a collection of providers in the city, we can try and ensure the safe and sustainable future of our organisations with all of the changes that's going on around us. So it's good to get that approval through so we can progress now to clinicians leading on the strategic case. I did want to reference the changes in the NHS in general, and of course we've had all these announcements around NHS England and ICBs and changes, and you'll, if you're keeping up with the sort of health press, you will see that yesterday, the first day where we started to hear from the centre about what elements of ICBs will remain, which won't, and it's a clear direction towards performance being, you know, the sort of regional focus, improvement, engagement, and that ICBs would be focused on strategic commissioning and neighbourhood development, as we know. In terms of how that affects us, I don't think it's going to be a huge change for us within our UHL and LASP space, because we've already got a clear plan in terms of the case of change and the things that have been discussed with the ICB board. So I don't expect any of that to materially change things for us, but it is a challenging time for lots of colleagues across the NHS, in ICBs and NHS England, who at the moment aren't sure exactly what's going to happen to their roles and to their responsibilities. So that will make it difficult, I guess, for us perhaps to have those broader system conversations in the short term. But we're clear what we need to do, and we need to just get on with that, I think. In terms of the rest of the agenda, I just wanted to note that Jackie has been appointed now as Heart and Chest Non-Executive Director as well, which is great. So as we know, Jackie's had the experience of both the women's and LUF now for a few years, so it'll be great to see her over at Heart and Chest with us as well, and the upcoming board meetings over there, and getting more into that side of the future organisation. In terms of where we are on performance, it's fairly self-explanatory. A lot of the stuff in here is talking about obviously February and January. I know when we get to the site hospital reports and some of the stuff that Beth's going to talk about as well, that we're going to get into where the year end. But I just wanted to give a bit of a signal as to what the last year's been looking like. I think we've ended the year now in a much better place on virtually every metric. I think if you take the urgent care position now, both in terms of where we look at February data is still slightly behind, but again, the hospitals will tell us where we're up to. But in terms of things like ambulance handovers, 60 minutes to see a doctor now, massive improvements in terms of where we've been. If you look back over the last few years, highest levels of those things like triage, 60-minute doctor time, and ambulance is certainly massively better as well. Layered on that, you've got the CQC view, of course, and we've got the draft report that rolled back, which I've referenced in other meetings, which was very complimentary about the quality and safety aspects of urgent care at the Royal. We're still awaiting the Aintree report, but again, we know that there were no significant concerns, which is a massive improvement from where we were over a year ago when there were. And really importantly as well, with the focus on productivity, we can see some quite significant shifts now in the organisation over the last year. And in particular, as I look at some of the information that we published through the corporate ops newsletter, which Beth's been sending out to staff recently, you can see sort of comparators of Q3 this year to the year before. 7,000 more people treated in outpatients, 18,000 more for outpatient procedures, 1,000 more people going through theatres than in the same quarter before that. And all of those within a context of reduced premium pay and reduced waiting list costs as well. So we can see the sort of overall cost of the organisation coming down, the numbers of patients treated going up, and certainly the throughput in terms of things like urgent care significantly better. I won't dwell too much on the where we end on RTT and on urgent care, because I'll just be jumping all over the reports. But I think that gives us some good context. The other thing I just wanted to raise was that the Women's Hospital is now a year into its improvement programme. We can see again through the IPR reports some really good metrics for the women's, in particular some of the staffing side of things, which I know Jenny's going to cover later on today. We particularly wanted today to talk about the Embrace report. That's why Chris has joined us. Thanks, Chris, for making the time to come and tell us about that, because there's a lot of national information coming out now around the most recent Embrace data, what that looks like. Women's often features in the articles on that because of the type of complexity of the work that we do. So it felt right today with that fresh publication of Embrace in March that we get to see some of the data that sits behind that. And Chris will give us a view of the things that affect that at the women's and what we should be concerned about and what we shouldn't be complacent about and all of those things as well. So it felt like a good time today to reflect on that as well. So I think broadly, Chair, in terms of the money, we are, and that's whisker away when it looks at the total size of the combined organisations from his plan this year, and Rob will get some interrogation on that shortly, I'm sure. And as we go into next year, a plan that is challenging but less than this year, and if delivered, will get us to a massively better place in terms of our underlying position across Luft, and then with a solution to the underlying problems, the remainder of Luft and the women's coming out of the case for change for last. So it's starting to feel like we're heading into a direction where we can point to improvement across the range of metrics, but still some big challenges to come. So I won't pick out anything else on the performance reports unless there's any particular questions on that now, but that's sort of how things look from where I'm sat at the moment. There is an attachment to my report, which is just the feedback letter on the CQC Broad Green Medical Care, which again isn't the full report, but I think you can see there again, really impressive from the CQC in terms of how they found it over at Broad Green. They're very positive in terms of their reporting back. So we'll await further CQC information and hand that over when we receive it. And the current expectation is by the end of April, we should receive all of those reports that we're outstanding, including well-led. And lots of managed expectations, I think, originally at the end of March. Yeah. So we've had an indication that well-led last week of April, and the other medicine and urgent care reports between now and then. So we'll look forward to receiving them. Thank you. Jeffrey.
Just picking up on the CQC letter, there's some really good stuff in there. I'm quite worried about the infection control, I thought, and looking for assurance really from David in terms of other sites you wouldn't find this in terms of lost notes, not routinely gelling each other. And do the infection control teams inspect each other as you've got multiple sites? You usually have an objective view of the site from a team. So some thoughts on that really, and assurance.
Yes, thank you. So yeah, I mean, it's interesting that they pull those issues out. The verbal report on the day wasn't quite as detailed as that, so it would be interesting to see what the final report looks like. However, the general principles are that our infection control team do have a site particular role, but they do rotate around as well. So there is an element of looking fresh at different areas. But it's important, really, isn't it, that the local leaders are the people who are the ones who are the guardians of safety and around things for IPC. And perhaps when we come on to the IPC later, sorry, the APR later on, I'll spend just a couple of moments talking about a slightly different approach that I'm taking with how we're getting better assurance of our own practice with IPC, as well as some of the other fundamental issues of care.
I just want to add some context on this. In the these letters that follow sort of immediately after, pick out, as it says there, the issues that they observed. The meeting itself was, wow, this is amazing. This is, and then you get there, but we saw someone that was that. So it's right and proper for that. So we expect the report, I think, to be significantly more positive than the list of the few things.
Well, it was a shame because there's so much good, and they
And it's a
key errors really.
it's the letter, and the letter will be the letter, but the report's the important document.
Thank you.
Thank you. Other points for James, please. Yes, Tom.
So I just comment on the CDT rates. I'd like to see the CDT rates have gone back to where they used to be. Have we ever uncovered a reason why they shut up temporarily and have now gone back to normal? Something obviously happened, but what was it?
Well, we don't think they are back to normal. It's sort of back into normal variation, but that variation is still at a higher level than it was a year ago. No, we've still been looking at this. In fact, we were talking about it earlier this week. Jim is working on stuff we've talked about in our strategic sessions about trying to get more of a benchmark quality perspective on this. But David and his team have looked at it. The rates are still high everywhere, but our full plot shows that we are still where you would expect us to be in that. So it's quite troubling really, because it's still higher across the country than it was, but we don't stand out as a concern. I mean, we have also had the conversation about, well, that's fine, but then what else could we be doing about it, which is obviously what David and Jim.
David.
Thank you. What we've also done is, because we wanted to get some external view, working with NHS England.
Chair, could we just ask people to focus?
Yeah,
sorry.
Sorry.
We've been working with a colleague from NHS England, an IPC specialist, who has come and reviewed our practices as well as our performance and how we monitor. And whilst there was some minor changes that they've suggested, they haven't seen anything out of track with other organisations. But what they've been able to do is look at the context of the communities that we serve and the rates of infection there as well. And that's not for us to be complacent. We should still be doing whatever we can to reduce hospital-acquired infection. And that's exactly what we're striving for now.
Thank you. Any other points? As James said in the report, look, so the April board is always one of those where, you know, we haven't got the full year analysis for everything, or the lead time for data. So that's the money or a lot of the operational stuff. And in any event, it's by definition the year's ended, so there's no further action we could take to impact upon the final position. So your summary, James, around a lot of the productivity issues on last year that we discussed throughout the year here, no, it is rightly a very positive picture about how the organisation is moving forward. Particularly impactful, I think, are the numbers of more people that we've seen go through our system at a time that we've been very financially constrained and will continue to be so. So when we go through the papers today on the money and on a lot of the operational and performance issues, our thoughts are not our consideration is really not in the frame of can we do anything to fix that now the year's gone. It's in the frame of where this starts for us in the new business year. Is our plan that we've discussed previously still consistent with where we think we're ending the year in terms of the brought forward issues, or are there anything that we need, any surprises late in the old year that impact upon where we want to be this year?
Yeah, I'll touch on a couple of those. The other thing I just wanted to pick up was on the agenda we had the NHSE group model review, which was the NHS England review, which was we were assured would be with us ahead of the board, but probably last minute it hasn't arrived, and Holly was chasing that up yesterday, and such is life with NHS England at the moment. The team who produced it now have got a change of director who wants to review everything that they've done, so we'll probably have another week's delay while that happens also. But in terms of the other things that have landed between publication of papers and board is a letter from the new NHS England chief executive, or the interim chief executive. No major surprises in terms of what we're already planning for next year in terms of the asks around the operating model and what plans will be. Obviously, major focus on reducing costs still. The two areas that came out that were clarity over when we last met as a board were the asks around reductions in corporate costs, and that's of all organisations. And that metric is now being based on a 50% reduction in the growth of corporate departments since a particular date. Now, we're just, again, crunching the numbers on that, but I think when we looked at that for Luft, we were already below what it was at that baseline. So there would be no reasonable reduction required, but we just need to double check that the understanding of the data is the same. For the women's, it was very minimal, but it was basically expected growth, basically. So that is an issue that we'll need to address, and that's something obviously that's on the last agenda anyway, because a lot of the other organisations around us have experienced significant corporate growth over that time. So if you take the whole Liverpool position, there'll be a job for us to do. So that's point one. The second one, and this is an interesting one again, because we were already looking at this within UHL, but there's been a significant focus on what they've called corporate nursing, but not frontline. So effectively, massive growth in the recruitment of nursing posts in a more corporate role, and where those are not frontline, an expectation that that will be reduced as well. So that's come out as headline number, but no further detail yet on exactly how that's going to be transacted. David was already looking at this as part of the programme of work that we've got, because there's massive differences in what not frontline means. Obviously, you can be not frontline, but a pivotal part of a team that affects the quality and safety of patients, or you can be not frontline and remotely working in maybe a different context that is easier to. So all of that we're just waiting to work through, but everything else so far has remained the same. The elected cap was the other bit of news, but again, not really clear. It just said there will not be an elective cap, which we all think is a good thing. But I also suspect that won't mean that the brakes are off and you can do as much activity as you want to earn more money either, because there won't be more. So we're just waiting for clarity on those items, but everything else that was in the plan the last time we discussed it remains the same.
Thank you.
Just a point on the CMAST update, James. Yeah. Given the sort of the changes around nationally and the ICB around workforce, do we see any increase their remit within CMAST, or as it always has done? And I guess the other point on CMAST is, given that we've got our group transformation plans and hospital transformation plans, how do we ensure that we don't have the sort of, a conflict of priorities around what they're doing and what we're doing?
So it's a good point. I think CMAST, for me, there's something about being clear around what the provider collaborative purpose is. It's a membership organisation to add value to a set of providers, that's fine. There's a risk sometimes that they become confused with an element of the performance management regime of the ICB. Now, we know that performance management regime is moving away from ICB, so it's going to be interesting to see how provider collaboratives sit within that context, because it's been easy for ICBs to say, right, let's just commission a lot of extra activity of ERF through the CMAST group, and they sort it out. So they've almost been in this odd situation of, we're paying a membership of an organisation that then is going to hold us to account on a number of things. I'm not saying that's wrong, but it's just an unusual dynamic, isn't it? When that performance accountability stuff moves from ICB to regions, I'm not quite sure how that would work. So what you'd want to see, I would want to see, is the provider collaborative being more around the value-added stuff that can only be done at Cheshire Mersey. And at the moment, I think, and I've said this clearly to CMAS, there's nothing that I'm saying here that I haven't already said in that group, is we sometimes run into the risk of, we've created provider collaborative that then is unable to do certain things because of the scale of the ICB footprint. And therefore, in that sense, we're better off in smaller groups of 1 billion, 2 billion scale, working under a CMAS plan, but delivering at a much more tangible level where you can actually get a grip of stuff. Whereas when you try and do things and insist on the same bank rate or the same electronic system from Macclesfield through to West Lancashire, it's just too big a footprint and too complex with too many organisations. So I think there'll be another iteration to go here about what CMAS does in that role, but I see it saying absolutely, and there's definitely things we should be doing on a broader level, but I still feel very strongly there needs to be almost a subset of 3 or 4 patches that sit in Cheshire Mersey that really work together on recovery. And Rob.
Yeah, thanks, David. James, just on the cap removal, I joined a national call latest today, and I think a limited time period consultation is likely to drop next week, it seems. And you're absolutely right. What they're saying is, yes, the cap's gone, but there's no more resources, and therefore it will be down to providers and ICB commissioners coming up with an activity plan and going back to really stringent activity management within that overall cap. So I think that's the situation.
Well, okay. So they've removed the cap, but they haven't. But
Thank you. It was just really a point on what Matt's raised. I think given the financial of this year, we need to look for opportunities to align our resources. And so with CMAS, they have a programme of work looking at pathways across the system, and we've already taken the opportunity to join up forces, particularly on two pathways, two of our most challenged pathways, i.e. the people that are working on that piece of work to improve. We're joining up our resource, and so hopefully we'll get improvement and deliver improvement at a quicker pace. So we just need to keep mindful of seizing opportunities where we can.
thank you. Jeffrey.
Thanks, David. Are they bringing the two provider collaboratives together now? Because I had the misfortune of being the nominated director of the Mental Health and Learning Disability Provider Collaborative Board, which was one of the most frustrating things I ever did, because it couldn't grasp its role. And
Yeah.
I thought the plan was to bring them both together now. Is that still the plan?
That is the plan. Yeah. I'm not sure when, but that is the plan. Again, that for me, that's I never quite understand why we had two provider collaboratives that were so intrinsically linked anyway. However, when you come back to the really collaboration at scale type conversation, for me there is a lot of logic in the mental health community providers doing stuff together as well. So it comes back to that thing. Let's have an overarching plan, and then different subsets of organisations where it makes sense just to deliver things together. It is a much cleaner way of trying to do it.
Okay, thank you. I think that the bit about corporate nursing posts and all of that. So, yeah, I mean, there's maybe, I'm sure David and colleagues will work through all of that. But to me, it's just evidence of when new people come in, they have, one or two specifics that they've got in their mind that there's something they want to do. I mean, it's very much a reach into something, because you look at this in the whole balance of how the organisation runs, what the governance structure is, what the leadership structure is, and so on. I'm not saying there isn't anything in it and that we shouldn't be charging.
Yeah.
It's an example of a bit of reaching of new people wanting to have an impact that we have to see through. It's like when new people come, it affects a lot of behaviours in the system of people, and fortunately we haven't got the time for this. There's not, there's a lot of people. Hi everybody up there, all you new people. Just want to introduce myself. My name's David. I'm doing a very good job. You don't need to look at you don't need to look at any objective evidence or what anybody thinks. You take my word for it. I'm doing a decent job. There's a lot of that going on at the minute as well.
I think there's a fundamental thing with, if you want to make it all about corporate nursing, but it's that, and we've been discussing this the last few days, is firstly, there's a number of things that are stronger and more consistent if they're done at scale. And I know that's not everybody likes that argument, but if you look at it, I can say this, having sitting in Liverpool Heart and Chest Hospital in my first meeting there yesterday, and if you look for, the resources from a corporate nursing perspective on things like tissue viability, on things like, in those smaller organisations, you might be one person deep, and if they're not here, there's no one. Whereas in larger organisations, you've got a team that can cover that and make sure it's consistent. When we were talking with Chris and Jim the other day, just around things like the difficult challenges that exist around the management of complexities of practice around doctors, for example, case investigation requires to train people in smaller organisations. You might have a very small number of case investigators. If there's a problem, that across the scale of a group like ours will help really support those organisations. So there's a logic from that argument. I honestly think there's another argument that possibly we might see coming from I hope we see coming from the quality agenda, which is, I'm not going to look at Jackie and David here because they might fundamentally disagree with this statement, but it's that thing of, in the good old days, well, let me put it this way. At Heart and Chest yesterday, my first day there, I'll put this on the record now. I can see lots of examples about why that's an outstanding organisation in the way that they do things. So just talking about another organisation in this board, I know, but to go there and sort of see their clinical teams presenting on the corridor to the exec yesterday morning, all the QI work they've done in the last month to improve things further from a safety perspective in theatre is fantastic. And you can see what they do. I think that's clinically led and it's great. And you do see, in my view, in the organisations I've worked at that have been the best from a sort of quality safety perspective, that professional advice is almost really embedded in the day job of the people who do it. And in the organisations where I've seen that perhaps not as well, it's because they've created large teams with specialist advisors over here on particular issues, and then maybe not de-skilled, but almost taking the responsibility away from the clinical areas to a degree. And there's a good balance in that has to be achieved. And I think all that's happened is they've looked at the growth in those roles and those numbers, and potentially there's an assumption that we're stocking up that specialist knowledge away from the front line. And there'll be different views on that, but I will probably share the one that says that it's all balanced. Okay. They're not shouting.
That'll all come later. Right. Let's move on and talk about the group-wide risk, please.
Oh, that's me. Sorry. Right. Right. So yes, we got focus to be today. Key couple of issues to discuss. So firstly, the risk around delivery of 65 weeks. Well, we knew that 65 weeks was likely to not be delivered to zero at the end of the year. And we were projecting at the last couple of boards a figure that would be as high as potentially 250 patients not being able to be treated within that time frame. I'd love to put everybody to be treated at Liverpool Women's. I think I'm safe to say the net result. Oh, hang on. Can we tell you the number? Is it 12? 12, yeah. There you go. I know the number. So yeah. So we've actually landed at 12 against that sort of 250, which on the one hand is fantastic work. On the other hand is really bloody frustrating because 12 is nearly zero. But there are some very complex patients in that list who need all sorts of things and specific surgeons and things. So yeah, the prediction of 250 breaches of that target at the year end is actually 12, which I think is very good in terms of the performance. So 0 for the women's, 12 for Luft. So the risk was escalated, as we know, and was right to be escalated because the 0 target wasn't achieved. But we also knew that was always going to be very unlikely. So so 12 patients at the end of the year. There's a corporate nursing safeguarding risk here, and this is we touched on it last time around mental health, and we had some concerns and still have some concerns about mental health input towards particularly and the impact that's having on our nursing staff in particular, having to manage complex patients who probably shouldn't be in an acute hospital environment. That's adding to staffing challenges and so on, and that number has been going up. I know David, the exec managing directors, will probably touch on it as well in theirs, and I know Jim has also been out talking to some of the Mersey care doctors about this. So people are on top of that, but the risk is still significant. So the mental health oversight group will be looking at all of that, and that's an attempt for us to really join the two organisations together to make sure that there's visibility on this and some improvement work in that space. So I'll put to questions in a minute if there are any. On financial services, again, those are the same risks that you've seen, that development of the plan for the year we're in, the financial balance, and those two items have been in there all year. Rob will obviously come on to that a bit later on. We had, as you know, an incredibly challenging financial target this year of circa 115 million CIP plus legal claim, etc. And we are circa 8 million-ish away from that at the end of the year, which is in a much improved position on where we thought we would be, but still not obviously a zero number. So Rob will come on to that later and can expect some challenge about whether post-year-end adjustments can fix that 8 million, I'm sure. And then the appointments risk, just to flag that We discussed this last time at the board, and we said that this was being reviewed because obviously the cohort of patients had been reviewed. The risk and the safety aspects have been reviewed significantly. There were no harms that we were finding in this volume of people. So that risk has been reviewed. That has now come out as a 9. So it's in the report to basically signal that that now drops off the list of the 12 and above risks, but it's still obviously squarely on the corporate risk register and still being managed in the same way that it was. So we will continue to validate that list as we look to harmonising across the group what the actual standard should be for that. But the patient risk has been proven to be significantly less than 12. So they're the key 12 and above risks that come through the senior management board. Obviously, these are corporate risks, and as it says in the report, if there are any corporate risks from Liverpool Women's, they come up through Jenny's report, but there's nothing significant flagging.
Point of questions for Jen? Mr. Mike.
Thank you. The mental health oversight group, I see the terms of reference still to be determined. Just a strong request. I have no doubt that there'll be a whole load of really important and good actions that will emerge. Can we make sure that we have a good means of tracking the impact of the actions and an accessible way of understanding have we delivered on fundamental change as opposed to delivering the actions that we said we were going to do? Yeah.
Before you respond, can I just build on Mike's point, because it might be in the drafting, but this has been a problem that we've been aware of for some time, and we've discussed the increase in impact of it. And we get to the point, and it might just be in the wording, but so what are you doing about it then? Well, we're having a development session at some point, but it got postponed in January. You know, where's the sense of, is it crisis meeting or a development session? Well, everybody couldn't manage to turn up in January, so we let it just run a bit longer. Is there an urgency and a determination to fix this problem more quickly? Because the way this is drafted, we'll get around to it.
So in the actions on there, that's in reference to the group-wide oversight group around mental health. Most of the significant issues in recent weeks had come up at the Royal, and it's the Royal wards where we've seen issues. So the Director of Nursing at the Royal has been having weekly meetings with Merseycare. It's in my site report to update. We've made some really positive progress around a new SOP in place for overnight patients in ED, shared management office now for the ED matrons with the Merseycare matrons, and we've got some positive KPIs and metrics that we're sharing with this week. That was primarily focused on ED. The meeting now that Lindsay is leading with the Merseycare executives around the ward support and particularly also of our care of older person ward. So there is a weekly task and finish at the minute between Merseycare and at the Royal. This corporate own risk is how we get a more in our governance framework and oversight group for all sites.
Sorry, I deflected from mine.
I'll come back to that. As you say, we've seen this before. So we saw this a year ago. It came through the same route. We had a problem. We escalated it to Merseycare. They resolved the problem. They put more consultants, not more, they put more that should have been back into the wards and resolved the problem, and it went down the risk register again. Every time it comes up, it gets managed through whichever hospital it is. So as Matt said, they're onto this at the Royal, they're dealing with the problem they have to resolve. This oversight group now is clearly, we can't rely on the problem being fixed and then maybe saying we're not in control of it. It's another supplier of the service to us that if it just falls away, we then just end up with risk popping up again. So this is now about how do we prevent that by having a better strategy going forward? Because the reality is the Royal is starting to feel like a dementia hospital where there's no capacity. That's not an acceptable position to be in. And now, again, I'm not going down the road. This is exactly the issue that we see every single time there are financial constraints on the system, is that everybody in the whole system puts the things that affect the acute system. So, I am very concerned that within the next year's plan, there is a multi-million cut in community healthcare. And what we're being told is, don't worry, it won't have an impact on the hospital. That's impossible. So if we can't have continuing healthcare, that's impossible. When the mental health trusts are getting pushed, they will stop purchasing mental health beds. Those patients will stay in the Royal and they'll stay in Intro. It's the same with everything. So this is systemic, I think, of this problem of the whole system's being gripped. So everybody drops the premium cost stuff. And the premium cost stuff is spot purchasing beds in the system to get people out of hospital and able to get stuck. So with that in mind, what this is trying to do is to say, well, look, if you know, back to the same old adage, if there was one Liverpool pound, you wouldn't do this. If there was one Liverpool pound, we'd spend it on the lowest cost solution, and that's not 4 nurses looking after 1 patient on 1 ward. So that is spot purchase that bed in the appropriate location for that mental health patient, share the cost of it, or we'll do something different. So that's what this is about. How do we change this going forward? And it'll link very heavily to the integrated care discussions that we're having in care already. This is where budget arrangements should be in place, because we just can't system to work where everybody cuts the bit of it that is their responsibility. Jackie.
Well, obviously, the Mental Health Act of Parliament, patients have their rights, organisations have their responsibilities. So for any patient being cared for within this organisation, it must be the ill health that's taking a precedence over them being sectioned under the Mental Health Act. But also as an organisation, we'll have to national returns on that. We'll have all to follow the legal requirements. So I suppose I'm just interested potentially how many we've got in at the moment, or what's an average number for us, and are we actually doing what we should be doing under the law, because I think that's really important.
Yeah.
So shall I respond? Thank you, Jackie. I was actually going to come in. So at the moment, or earlier on this week, we had 7 patients in the Royal Liverpool Hospital who were sectioned under the fact. Some of those needed to be in the Royal Liverpool because they still had some ongoing physical healthcare needs that was cared for in other environments. But those 7 patients, the majority of them need between 3 or 4 extra members of staff to care for them because of the behaviours of concern that they have. That they are clinically unwell people and need to be cared for in appropriate environments. And whilst our staff are committed to provide compassionate therapeutic care, it isn't the correct environment for them, for those patients. And they're making the best efforts, but it's incredibly challenging. And I think that's where we've started to come to get another peak, as James mentioned. We come to an arrangement because of the circumstances, and then we move on. But actually, it's into another crescendo, and it feels very, very different from what we've had in the past couple of years.
Beth?
Mine wasn't mental health related, and if people want to.
Okay, I'll come back to you, Jeffrey.
There was another issue developed 2 years ago, exactly the same issues. And we got our MP to raise the issue in Parliament because it's out of sight, out of mind. You're 4 staff looking after a very troubled patient. It was also troubling to other patients on the staff. And the real issue was the lack of secure and complex beds nationally. So you're looking around the whole country for patients. And you look at the cost of that to the taxpayer and it's with the impact on the patient. And there was just no grip of it we could see. And I think there are things you can do locally, and I agree about this Liverpool pound, where there might be a local community. But ultimately, the issue is about lack of beds for these complex patients. And nobody seems to have an issue. Nobody seems to have an oversight of that.
Well, those beds were being spot purchased. So they are there. They might not be in the best location, but they are there. But that location would still be a better location for that individual than a hospital ward. And that's our issue, isn't it?
Okay. Can we have an update at the next board with a bit more analysis on what this?
Yeah, absolutely. I just want to
know, as Mike said.
Yeah, I just want to. So on that bit of Mike, so the most likely indicator will be, as David said, the number who shouldn't be in hospital and the staffing costs associated. Probably the broadest metric.
And then just to final comment, they're the patients who are sectioned under the Mental Health Act. There are obviously a significant number of other patients who are equally in hospital who need to be in another place of care.
Back to Beth.
Thank you, Chair. It was just really to make a note around the 65-week next meetings. We will not see poor risk associated with the delivery of 65-week. We will be changing that risk accordingly because in light of the 25-26 operational planning measures, which will change from a focus on 65-week to no more than 1% of our patients on the waiting list will be waiting over 52 weeks. So I think that's important to note, and that we will be seeing that particular risk and that particular metric here future. Thank you.
Getting down to 12 is a better position than you'd manage our board's expectations for over the last couple of meetings.
Well,
Yeah, those 12 people been seen since the end of the year, Peter.
Not quite yet, David. I mean, it's some of the complex patients in there around choice and when they want their procedures and stuff. Some complex stuff around diagnostics that fell out of the work we put in terms of what do you need to get in your procedure. So we're just working through that, but I'm hoping we'll get that number sorted.
Just to respond to that comment, the reason that's 250 to 12 wasn't a under promise over deliver type situation. At the point where we had the 250, we were told that we would not be paid the premium rate.
Yeah.
ENT had a network, and then Rob managed to get a conversation with the ICB that said they would fund it till the end of the year, because if you remember there was a cap on electives again, wasn't it? Suddenly appeared in December, and then they managed to take us, and that allowed us to do that work and be actually paid for doing it, which is the only reason, because a lot of that was Saturdays.
Yes.
Or actually, was it? It's the only reason we managed to get that through, otherwise it would have.
Understood, thank you. Well done, Rob. You must be spending a lot of time stood behind bike sheds.
Moving on.
Can I raise it? Sorry, Rob, that seemed to have an impact. I didn't.
That reflects on the board chair rather than yourself.
Can I ask about the one of my favourite subjects, the overdue outpatient appointments? Can someone talk us through? So we have these 200,000 numbers we've been looking at, and there's been a discussion we've had about the rate at which we work through this. Now we've worked through 51%. So there's a broader point here, not just about the follow-ups, but about the way in which the risk score. So we've looked at 51%, so there's still nearly 100,000. But on the back of the look at 51%, we've de-risked from a score of 12 to a score of 9. I'm not saying that's wrong, or I could just understand how the thought process works on that.
So one of the things is we've looked at in other organisations, because as I've said before, this is an issue that exists in every NHS organisation. So it's not some of that again. We put it in here because we felt it's an issue that's often ignored, and that there might be potential risk in that space. So I used the Chester example before. They have a metric where they would not want more than 25% of follow-ups to be in that situation, with a sort of backstop date of however many months wait. I think that's probably a good way to approach it. So that's what we want to look at. The critical thing about the risk reduction is having a look at the volume as a proportion of the total number of people that we see. And 100,000 is a lot, but it's a very small proportion of the number of outpatients that we do in this hospital in follow-up settings. So it's not, the bulk of what we do. It's a very small proportion. So if we compare that to other organisations, it's back to that scale of organisation versus proportion thing. That proportion is not a huge concern. And if we move to that model, we would probably be within that sort of threshold that we think is reasonable. So Beth and the team took a view for that reason. That the consequence is obviously a reduction, which is unusual, but the consequence actually is now we know what we know about the risk side of it, the safety incident side of it. Likelihood's clear, and we have got controls in place. They're just particularly likely to be. So that was the rationale for it. But as I've said, we're not removing the risk, we're just changing the score. What we then want to do is have a look at how should we look at this across LASP, because this would be a really interesting metric to look at across LASP, because largely you'll find this problem, particularly in very specialist services, and it could be that the last position is quite scary when we look at it. So that's the next step, is to look at it.
Okay, thank you. David?
Thank you. Could I just pick up on Beth's point about the new waiting list target? We've had a 65-week target, we've got that down to 12. That's a tremendous achievement. I don't, and apologise if I should pick this up from the detailed stats we've got in the pack, but I've got no grasp of how getting down to just 1% of the waiting list waiting 2 weeks, whether we cruise over that target or whether it's another really demanding target to hit. What's the feeling?
So we're still working through all of that at the moment because we've got, and that's not the only sort of stuff. We've been asked to do a 5 percentage points improvement. So do you want to just comment on function the numbers and we'll change the report? So
it is going to be a challenge for us, but the detail that we're working through is at the moment, there are marginal gains to be had in terms of productivity, in terms of how we book and schedule patients, etc. So this is very much tied into our improvement programmes. So that's why we couldn't give you a definitive. I think around the challenge looks as if it's going to be around 5% in terms of where we are now and achieving that 1% that I've just quoted. But that's what we're working through out of that 5%. How much of that is due to capacity challenges in some of our specialties? But then how can that be mitigated in some of the marginal gains that I've just referred to? So that's the detail that we're working through.
So before the next board, when we start to move to talking about the new metrics, we'll obviously put a paper together that lands in the next board that says, here's what we used to measure, here's what we're measuring now. And so everybody's clear what the rules are, because some of that's still being worked out with the planning regime. The interesting bit is if you take the overarching dashboard, what you can see is our total waiting list size coming down, but the 52-week numbers pretty static. So that's another challenge for us because that number hasn't been coming down for the last year. It's pretty static. So we assume therefore that we are going to need to see it improve.
Peter. Yeah, it's a good point. And just to briefly say on that, some of those risks will firmly sit with the injury, particularly around head and neck and ENC, max, and a little bit with orthopedics. But we are working with Beth's team to work those things out, and that's exactly why head and neck is in our group transformation plan, and because that's where we need to focus to get some of these markets running. And probably will see that risk bubbling up in the injury risk register for the operation.
Okay, thank you. And Tom.
Thank you, David. There's a different point, and it comes across reading through the papers as a whole, where there are odd hints that our tight vacancy control on non-clinical facing jobs is starting to impact on clinical facing jobs. So, for instance, there are a number of points where a specific example arises in relation to medicine safety, where the medicine safety plan is stalled, not progressing as fast as we would. And the reason is because we haven't had the HR staff to appoint the clinical facing staff who would have addressed the medicine safety issue. And that arises in a number of points. None of them seem very significant, but there's just a slight trend running in there that we need to be aware of.
I'm just coming on the spot. So this is a good example of sort of what I was explaining before about in the current world, old world, that I'm hoping is going to change now this year, because of the financial controls that have been placed on organisations in deficit, but not on organisations who are either on plan or in surplus. We've had imposed vacancy freezes at Luft, but not at any of the other organisations that we're working with. And what that's led to is a significant reduction in the corporate numbers of posts that have been able to be held at Luft, whilst other organisations locally have in growth. And that just isn't the right way to manage the system, to be honest. So the conversations within last week then will look, that's got to change this year. This corporate reduction target that's been applied now is going to hit the other organisations, but not Luft, because Luft is already below the area that we needed to get to in this year's target, which should now allow us to say, well, look, we're going to bring these corporate services together. So if we now do that at a much quicker pace, there's a number of benefits here. One is it will help the other organisations to get to the target they need to get to individually, because it will be a slight reduction in theirs and a slight increase in ours. But if we can start getting people to understand this as a single system, then A, we can probably get to the numbers quite quick, and B, we shouldn't have to have a whole load of sort of difficult change management situations where there's not enough jobs for the people. So it gives us the chance to align that quickly. So we've got meetings on Tuesday next week, but certainly the last portfolio board and the SROs have all agreed this week we have to align the corporate services rapidly this year now to solve this problem. We can't solve this problem by Luff going spending a load of money it hasn't got, putting a lot of posts back into the system that by the time they arrive, we'll be doing the change management process to again. That's got to be the solution then.
Yeah, and I think this is a good example of where we can get to a better place for service delivery and for the staff involved by working together and doing it as one that we could if we were all doing it separately.
And in addition to working together, it's also around working differently. So I just coming back in on, there are some posts being held knowingly whilst we assess the impact of automation. So I was on the LCL vacancy panel yesterday, and there are some posts that we are still quantifying the positive benefits we're getting from automation, but that can also apply to admin staff, which, you know, Natalie's raised several times around how we automate some processes, and also medical safety. Actually, there are plans to automate some of their processes, but we need to think differently, and we need to spend money in a different way in terms of investing in that automation. So we do know that there are some areas, but it's not a risk. Well, we are quantifying the risk associated with that automation before we want to have that. Thank you.
Thank you. Okay, let's move on into the site reports now. If anything then that we want to come back to in the IPR as we've gone through the sites, is that okay?
That's fine. I was only going to reference that you'll all see the cancer and FDS performance as an issue. I haven't brought that out here because you're going to hear it.
Yeah, okay. But we'll come back to any outstanding issues or concerns people, questions people have on the IPR when we've gone through the sites. And we start on the sites with Jenny, Liverpool Women's Management Board. And then, as James said, Chris is here to talk us through the Embrace issue, so we will focus on that. And then, for flow of the meeting, discussed with Jenny, I'm going to bring forward the perinatal quality surveillance dashboard and bolt that on the end of the women's site. Is that right, Diane? Yeah. David, you all right with that? Yeah, okay. So Jenny, over to you.
Okay, thank you. So there are 3 high scoring risks appearing in the board this month. Risk 2764 in relation to pharmacy. Our chief pharmacist has raised a number of risks which are being overseen by the hospital management board, and the risk that's escalated is the totality of those individual risks combined. We are working with the chief pharmacist as part of the transformation plan for 25-26 to prioritise the business case that was presented to hospital management board a couple of meetings ago, and we'll look at those actions in the context of the group and LASP. As I say, that risk will feed into the transformation plan as we look at the totality of the medium risks across women's hospital services on the site, and we'll prioritise those risks in that context. And we'll see that plan for the next hospital management board along with any immediate actions. There was a small investment into additional policy controls agreed, but the totality of the business case was over £1 million of funding, which was not possible. So it's how we do things differently to address those risks that have been raised. Risk 2989 in relation to long-term financial sustainability. Again, we discussed and reviewed this with the management board in light of the very challenging planning round and the ongoing deficit position. We discussed whether there was more that could be done to improve the control score, but it was noted that the controls available to the trust in terms of efficiency and expenditure and the things that we have within our control weren't enough to eliminate what is proportionally a very high deficit in relation to the levels of income and expenditure of the trust, and recognising that the 3 key drivers of that deficit couldn't be resolved by the hospital alone and really are reliant on external factors. So around our economies of scale, investments in safety on site, and also CNST and tariff. Our CNST is incredibly wasn't expensive for us, and tariff, while we welcomed an increase, didn't go far enough to cover the costs of delivering maternity care. We also noted that Birth Rate Plus review on the workforce within maternity services will indicate that the current baseline establishment has a shortfall, and that we will need to further invest to meet those standards. That is in our financial plan for 25-26, but it's not matched by funding, which just exacerbates the size of that deficit. Risk 2770 remains as a 13. That's around anaesthetic cover for out of hours emergencies. Improvement work has made that rota more robust, and we have also our improvement work in relation to the single anaesthetic service ongoing with colleagues at the Royal with a task and finish group set up, and we're working through that. The risk is being reviewed in the context of the relative stability of the rotas at the moment, and then the future state as we work through. In terms of finance, I won't go through too much detail. I shall leave that to Rob. But we did have a slight adverse variance in month and year to date, but we are on plan to deliver the revised deficit of full year of 11.6 million. We had 5.7 million CIP to date, but we recognise that a significant portion of that was non-recurrent and would cause an issue moving into next year, and capital spend was moving in the right direction to meet the full year budgeted spend, and we had a cash balance of £5 million, which was encouraging. In terms of performance in RTT for 65-week waits, we did have one patient pop on in February as a result of a late addition to the list, but that patient has been treated and the pathway completed. It was 0 before that, and we're expecting that to be 0 again at the end of the year. Some really positive news on the 28-day faster diagnosis standards. We achieved the national standard at 77.3% for the first time since COVID-19. Which was really, really encouraging and reflected the really hard work that's gone into these. Cancer 62-day increased in months to 44.2%, which demonstrates continuous improvement. However, this does remain below the national target. In terms of our diagnostics, we did see a significant improvement in months from 69% to 94.6%. We've got the recovery actions embedded in that, and we hope to sustain that improvement. In terms of never events, there were no new never events reported, and 3 within the rolling 12-month period following the removal incidents which were more than 12 months old, which had previously been reported in the OPR data. In terms of IPC, infection prevention and control, there were no further MRSA or C. diff reported, and therefore that KPI was no longer concerning. Staff fill rates are now reported in the IPR at board. Not come up to the last couple of months. They are within the report. We did have a question come in last night, which I will just take now around staffing, if that's okay. So it was around some Channel 4 news, which had revealed the gap between planned and actual number of nurses. I don't know, I can't validate that data that's come through. I can't get through on the link, but it talks about Liverpool Women's having a 17% shortfall in maternity care of nurses and midwives, which doesn't ring true to me. So we can go back and look at that data. Say, I can't follow the link, but we will send you the information of the actual numbers. But I think what's probably more important is through midwifery, we're fully established, and we don't have any concerns across neonatal or gynecology. Nursing in maternity, we check the staff rates every 4 hours based on acuity and flexing for what's happening on the ground. So whilst you can see the fill rates in the NPR as well, the reality of the situation is something different. The fill rate is quite a crude way of measuring staff. So not concerned for us at Liverpool Women's, but what we will do is collate all of that data and just show you the gap to whole-time women's establishment as well. Okay. Moving on to the rest of the report. So we went through our maternity and neonatal services update, and we took good assurance again on the maternity and neonatal 3-year plan across the 4 themes that are there, which are around listening to working with women's families with compassion, growing, retaining and supporting our workforce, developing and sustaining a culture of safety, learning and support, and that we've got standards and structures that underpin safer, more personalised and more equitable care. We received the perinatal dashboard, so just some updates on that, and then we can bring Di at the end if there's any further on that agenda item. So there was one stillbirth reported, which was subject to rapid review. You'll see 1.9 in the IPR, as we've discussed before. That is an adjusted measure. All reviews of perinatal mortality are supported using the National Perinatal Mortality Tool, the PMRT, with case details, learning actions reported in the Learning from Deaths report. There were no patient safety incident investigations reported in month. You'll recall from last month, we declared full compliance with Maternity Incentive Scheme Year 6, and we submitted the final response. We are expecting a formal response imminently to whether we have passed or attend standards on those in terms of being able to report that. There were 2 cases identified where there was no one-to-one care in established labour. There was no harm identified in those issues. And delays in inductions of labour, while we did see an increase on prior month, it still represents a decrease from where we were earlier in the year, where we had some concerns around the levels of inductions of labour. So finally, from me, before picking up a further question which came through last night, we did also approve the establishment of a new digital hospital board in the new structures, looking at what we delegate to site and report through the hospital management board and what then is held more centrally and corporately through Matt's team. So the question that came in again, just to pick that up for people. So there was a question. It's actually in relation to the diversity, equality, inclusion paper, but I'll pick it up here so that we can just sort of be specific around that. So there's questions around what happens for women's when apprenticeships finish for targeted groups, including disability, and do all have guaranteed job interviews, a job offer, and support to apply to other roles. So just for the board to be aware, we do have pre-employment programmes. We run a variety of programmes in partnership with DWP, the Department for Work and Pensions, and local colleges such as Freebird. The participants on the programme get an NHS reference as well as get their skills and experience. And we try and time the programmes with expected vacancies within the organisation. And participants in the programme have got guaranteed interviews in the last 12 months, and some have been successful in gaining roles across some of the hotel services, pharmacy, administration, and they can get bank roles as well. So it's a really good scheme. The majority of our apprenticeships are undertaken by existing employees, so they are already in the organisation as employees. And just on that final point around the guaranteed job interviews, we're one of the only trusts and countries that offer a guaranteed interview scheme to applicants from the global majority, which kind of mirrors the 2 Ticks national confidence scheme. So we do that for global majority, and we're monitoring that through how that makes a difference to our intake and our business. So I'll pause there for any questions.
Thank you. Questions?
Thank you. It's on the financial sustainability piece. There are 2 things going on. One is the opportunities around LASP that we talked about. Then there's a more specific thing around tariff and CNST. The experience of the right staffing at the new Royal is it needs a long and sustained campaign, and in season out of season. Have we got a planned campaign and sustained campaign around lobbying on CNST? And if so, what are the core elements of that plan?
So in terms of CNST specifically, that is based on the actual payouts and actual premiums, and the maternity incentive scheme itself and the 10 standards are aimed at bringing that down. When we challenge the question around we've consistently achieved apart from in year 1 and premiums are not changing as a result, what other levers have we got to bring that down when it's based on such a complicated effectively conversation around specifically maternity payouts? We do lobby, we do speak to NHS Resolution, who run the scheme, and Rob and I has got a meeting coming up shortly with them around the level of contribution for Liverpool Women's. It is a product of maternity and the size and scale of the payouts if there is damage to the baby. But we do work on that, and we have done for a number of years. We haven't seen the premium move other than a number of years ago when we had a small deferral. It is very difficult to influence the CNST payments. We do lobby around tariff. Our Director of Midwifery is very vocal in that area, and we have done some work with trusts across the Northwest and around the tariff versus premiums, maternity required to pay through CNST, and indeed the investments through Ockenden and all the reviews. So we continue to lobby systematically.
Is there more we should be doing from board level to support?
Potentially, yeah, I think so. I think we've tried in the past, but absolutely, I think it's more around that raising awareness. What all hospitals delivering maternity services will be in this predicament in terms of deficit. The difference is for us as Liverpool, as an individual organisation, as the proportion of maternity services we deliver in that totality. But now that we are more, we've got more kind of clout, if that makes sense. I think it would be helpful to do, to sort of support that.
Question on so spend. We often see this, don't we, towards the end of the financial year. There's always a real sort of what to spend. You know, and I think it was what's £4 million cost the group to be spent in month 11. And I just, you do think, you know, with all the other financial sustainability and the focus on reducing operating costs, does capital, and probably a question for you, Rob, really, does capital really kind of take a backseat in terms of that spend?
I'm not sure it takes a back seat, but it's a lever that can be pulled probably more easily. Get a financial framework for your revenue costs. They are largely staff, you know, and operating expenses. Capital often is perspective, isn't it? So they give you capital and then you go and spend it, or you know you've got plans to utilise it. So therefore, the theory is that's easier to turn off. And similarly, the proposition is it's easier to turn on as well, which is often why you get these last quarter kind of availability of funds. Also, at the end of the year, we have to account for accruals and everything that we've received and have not yet been invoiced. That's often why you see a bit of a spike as well. But there is no doubt that capital is going to be limited, and I think there's going to be more specifically pointed going forward. There's also the issue of cash, that actually there is a view that if organisations are in surplus, they have more opportunity to access, perversely, to access capital and spend the money. If you're not, and that similarly, there's a view in the planning guidance that could reduce your capital availability, probably for the reason it can. So it's actually that, you know, if you're doing well, you can spend more. If you're not, then capital will also slow.
Yeah, just as, yeah, sorry, but I've been triggered by Matt's question. I'm going to sound like a stuck record, so just be prepared for lots of Liverpool heart and chest examples today. But we are squandering capital across this city because of these separate organisational things. You only have to look at that and just look at you've got porter cabins stacked up outside the heart and chest because there's not enough land that belongs to the heart and chest to put them in the perfectly empty field that's next to it, because that belongs to someone else. In what world would you do this in what's supposed to be a single NHS? So we're spending money on the wrong things in all these organisations trying to build these separate little sort of empires for the last 20 years, and it's ridiculous. So one of the big major issues now is getting a single capital plan across those organisations. The financial rules will make it difficult. We've got to find a way through that, because we are literally wasting money. And you've seen it with some of the digital relationships where we've got kit that's redundant now because it's the wrong stuff. We've got, you know, it's mad. So I'm convinced we can get much better value for the taxpayer out of that. Just look at it as 5 organisations now.
Yeah, absolutely. Very good. Thank you. One for me, Jenny, on the 62-day cancer RPMT, as the report says, making progress. Still a long way off standard. Can you just recap for us what the constraints or the limiting factors on that in capacity terms are?
So it's the volume of referrals fundamentally when coming through, and then our ability to get through all of those referrals within the given time. There are some issues around late referrals, around tertiary referrals, etc. But fundamentally, it's trying to get through the volume in gynecology. Gynecology particularly challenged.
So is that's the staffing constraint?
The capacity constraint.
It's capacity in terms of staff, though, isn't it?
Yes, yeah.
You know, if we have the specialists in gynae cancer, we could use an empty theatre, but there's a finite resource of them, and it's a problem. So you know that's been part of obviously what the women's want to be able to do is to, as we are the specialist centre, if we can grow that specialist workforce, there's a limitless supply of patients who need it. It seems the waiting times nationally are still so big. Gynae and ENT are pretty much the 2 biggest wait times in the country. In general hospitals, and your average district general hospital, it's been a few years now since I worked at one, but my guess would be there's probably got about 4 or 5 ENT surgeons, probably about 5 or 6 gynae consultants. So they're very fragile, and therefore anything that's slightly complex just heads into the specialist centres, and as we see with the NT and we see with the women's. That should be a positive if you can develop and train and get those posts in, shouldn't it? Because it's again, a supply line of work to do. That just takes time to catch up. So one of the big things this year, as Pete said in his improvement plan, is how we're going to grow the next set of head and neck consultants to improve likewise in the country.
Thank you. So, Jenny, do you want to just steer us through now on perinatal report and the embrace study in the best order?
Absolutely. So I've picked up some of the issues from the perinatal dashboard in my report, but I'll hand over to Di. Anything else you want to outside?
Yeah, thank you. So just to assure that we have a really good kind of review at FNB back in March with, of course, our obstetric and midwifery colleagues. The set of metrics are pretty familiar to you all. You've seen them all. Jen's alluded to some of them. Just wanted to bring out and be clear that because the MIS Year 6 has been signed off, it doesn't stop, it continues. We continue to do the work. We continue to provide assurance to the LMNS, who on behalf of the ICB provide that oversight and scrutiny. So those things continue, and we continue to receive positive feedback around our approach, which is, assuring in some ways. In terms of the update in here, just the to bring to the board's attention is the ongoing work of the board safety champions, which of course Jackie is involved in, and some points highlighted there through the recent talk about, which is an opportunity for staff that work in those areas to raise anything specific to them. And of course, we have an increasing concern raised by staff around some behaviour of families within our neonatal unit, and there's some actions in there that we're picking up to look at how we contract and how we support families in that very stressful time, and of course support our staff. The detailed in there around saving babies' lives, which is incredibly important. That's probably one of the key elements of the maternity incentive scheme, and you can see the increase in training figures, which is good to see. But apart from that, I wasn't going to bring anything out. It's a detailed report. Going forward, this will form part of the Trust Integrated Performance Report, so you'll see it in a slightly different format, but it will still get the same due diligence at the Hospital Management Board as we go.
Thank you. It's a very good report, very clear. Any points, questions? To receive. David?
No, I think the question about the staffing and the question working on has been answered by Jamie.
Thank you. Excellent.
Thank you. So I'll just introduce Chris Dewhurst again, as before, our medical director at Liverpool Women's, and you may have seen reported more recently performance data about neonatal mortality, something where we have had some outlying results, I think it's fair to say, for a number of years, but there are complications around the way that we are set up in terms of a tertiary centre, and there's, we've been looking at this for a number of years. So we've invited Chris today really just to talk through the complexities of the data and how it's reported, and how, whilst we can show as an outlier, how we keep reassuring and assuring ourselves that that's not because it's bad practice or we're doing things wrong, it's how we're benchmarking and the complexities of the cohort of babies that we are dealing with at Liverpool Women. So I'll hand over to Chris.
Thanks, Jen. I do have some slides, so I don't know if they will.
Yeah,
that'll be easier. Oh, you've got them in your packs.
We got them ready to present.
We have a 44% hit rate on working. I mean, if we can just take a minute to get them, it would be helpful. It's the way we can do that.
Whilst they're loading, I will explain. So a neonatal and perinatal mortality sounds like it should be a relatively straightforward constant and measure. But for those of you who sat on the LWH board, you've seen me explaining the intricacies of the data and the different ways that we collect data, report data, and different ways it can be benchmarked. To put it simply, the mortality data can be put very different ways in terms of different populations, different gestational ages at different points at which babies will die, and the different points at which gestation may come into play. So what I'll hopefully do is take you through perinatal mortality, which forms the embrace data recently for 2023. And it's this data that most external to our trust reviewers look at, and it's this data that makes the press because it's clear. It comes out with red dots or amber dots, and the press can understand that, pick up on it, and then that's what is published. And I'll explain it in a bit more detail. Hopefully. Am I in the 44 or the 56?
Hit rate's gone up now.
Well, it's probably easier than some other dates. So if we just move to the next slide, please. So what do we mean when we talk about perinatal mortality? We mean stillbirths more than 20, in the terms of Embrace, stillbirths more than 24 weeks and neonatal deaths within the first 7 days is your classic description of perinatal mortality. Embrace use extended perinatal mortality. Stillbirths more than 24 weeks, neonatal deaths are in the first month of life. And this is judged to be a marker of maternity and neonatal care as a quality measure. Important, I don't think it's a safety measure, because if you are less than 24 weeks born, and we look after babies from 22 weeks, or if you die on day 29, you don't appear in this data. If you are born in another hospital but are transferred to Liverpool Women's and die at Liverpool Women's, you don't appear in our data. If you're born in Liverpool Women's and transferred to another hospital, you do appear in our data. So it's all the births within our data. So just go to the next slide, please. Very briefly about Embrace. Embrace collects data on neonatal deaths, stillbirths and maternal deaths. They produce reports every year on maternal and neonatal mortality and stillbirths. And then the reason this has become a hot topic recently is the 2023 data was published about 2 to 3 weeks ago. Just to remind ourselves, these data include stillbirths plus neonatal deaths up to a month of age. It excludes terminations of pregnancy, for want of a better term, or feticides beyond 24 weeks, which do occur at the women. Then what Embrace do is they benchmark similar looking units, and for Liverpool Women's, we're benchmarked against level 3 neonatal units who have neonatal surgery. We have to be cognizant of the fact that Liverpool Women's also delivers babies with cardiac conditions from the northwest of England and Northern Ireland. And that is one of only 9 cardiac centres. So we're not necessarily like all of the hospitals that we compare with, even within our comparator group. The data is standardised and matched for mother's age, deprivation based on where the mother lives, ethnicity, sex, multiple birth and gestational age. So with an aim to make it that the populations are similar when we compare between trusts. The concern I've had with the way that we Embrace look at deprivation is that they look at it at the quintile level, i.e. the 20% level, and not at the decile, the 10% level. I think that's important for us, because if we look at our population in Liverpool, it can look very similar to other cities around the country at the quintile level. Decile level, very different. Next slide, please. So these are the data, the headline data. On the left here is our mortality rate, standardized and stabilized, with each dot representing an individual trust. The data in each individual trust is then compared to the group average and is given a rating or a colour: red, amber, yellow, or green. And you can see Liverpool Women's is red, which means we're more than 5% higher than the group average for extended perinatal deaths. This includes all babies. We look over on the right-hand side, the right chart shows that Liverpool Women's is in amber, and this is when congenital anomalies are removed. Next slide, please. So, sorry, if you just go up to, so we know that congenital anomalies have a large effect on our number of neonatal deaths, and nearly half of the deaths at the Women's are in babies with congenital anomalies. So they are delivered at Liverpool Women's because of the specialist nature of the services we provide, including those cardiac defects. That compares with about 1/3 of the deaths nationally. So the question coming back to, is it our population or is it our care? So this is showing that some of the reason will be the population of babies we look after. Next slide, please. We've known we've had a high mortality for several years. On the left here is the extended perinatal mortality with congenital anomalies included, on the right is excluded. If you look at the last 3 years, we've seen a reduction year on year in extended perinatal mortality, and on take congenital anomalies out, we have been within the group average for the last 3 years. Just next slide. Here we go. Next slide, please. So within extended perinatal mortality, we have stillbirths and neonatal deaths. What we've seen at Liverpool Women's, probably due to some of the stuff that's been coming through on the perinatal dashboard and the Saving Babies' Lives, which is around trying to prevent stillbirths, is our stillbirth rate has dropped dramatically, and our crude rate for 2023, sorry, was actually below the target to half stillbirths by 2025 to 2.5%. So we were below that, which is pretty outstanding, I think. So we can see on the left-hand side that the stillbirth rate is very low. When we look on the right-hand side, it's on neonatal mortality, which is high. These two things are not independent of each other. So a low stillbirth rate means that we deliver the babies, get them out, but then they end up being sick babies who may die as neonates. Next slide. What we have to just go back to that one. What we have seen is a fluctuating neonatal mortality rate. So that slide there is the neonatal mortality rate over the last 7 years. It was red for the first 4 of those years. Then we were within the average. Then we were below average. And this year we're back below average for the neonatal deaths. Next slide, please. So what have we done about this over the years? A number of things. As we said, is it our care? Is it our population? To look at is it our care question, we asked, we invited external reviews when I was clinical director for neonates. We asked Birmingham Women's to review our care. We asked the North West ODN to review our care, particularly focused on extreme preterm infants. The summary of those reports was there's no clear causative factors. Action plans were developed, completed around individual care pathways. There was some interesting information of different patient flows. So we know that we see 3.5 times the number of babies transferred antenatally to Liverpool Women's than our neighbour in Manchester. We've achieved the maternity incentive scheme, part of which is the Saving Babies' Lives Care Bundle. This is where we try and prevent stillbirths, and that's been successful. And we have a quality improvement work on preterm optimization. This looks at 7 care factors that will improve the likelihood of a preterm baby surviving. And we're seeing great data coming from this. This is work led by Alex Cleater on the neonatal unit. The LNP, we have increased cross-site working between the Women's and Alder Hey. And we've got the new neonatal unit in January 2020. And we're further investigating these data. So I've alluded to the fact that we have 3.5 times the number of transfers of babies into our organisation than neighbouring, and why that is. We see babies don't follow agreed pathways within the region. So babies from, for example, East Lancashire, who should flow into central Manchester, are coming towards Liverpool. We've got a public health registrar who's looking at our pathways and demographic factors. There is that pool of patients. Is it pulling in high-risk patients who are likely to feature in our data? And colleagues in the University of Liverpool are looking at comparing preterm demographics. So to answer the following question, is an extreme preterm baby in Liverpool the same as an extreme preterm baby in Oxford? If you look at Embrace data, all of the green dots are down in the south east of England and London. And as you move north, you start to see it becoming amber and red. So that either tells me there's a difference in the population, or the doctors and the carers of the babies are not as good in the north of England as in the south of England. I think the way I presented that gives you my views. Right, next slide. So in summary, the reason this makes the headline is the first of those slides is the slide that hits people's inboxes, which is extended perinatal mortality rate is more than 5% above the group average for 2023. When we take congenital anomalies out, we are within that group average. About half of the deaths of our babies have congenital anomalies. We've seen a falling rate in the last 3 years, and we are within that average when congenital anomalies are removed. Seen a falling stillbirth rate in the last 3 years with a fluctuating neonatal mortality rate. We've done previous service reviews, we've got ongoing data analysis, and ongoing QI work. And when I look at the data we've submitted to Embrace, we see a lower neonatal mortality for 2024. This isn't standardised nor adjusted, so we can do the benchmarking, but we've seen a nearly 40% reduction in neonatal deaths in 2024 compared to 2023. So I'm happy to take any questions. I hope that was understandable because it is a slightly complicated issue.
Thanks, Chris and James. I've got 2 questions. One's probably a massive oversimplification, so just help me to understand it. So I understand everything you've explained there. The data's got the here's us compared to everybody else, and then it's got here's us if you take out the congenital issue.
Yeah.
But you also referenced 9 sites that are very specifically similar. Have we ever looked at those 9, or is that just too much of an oversimplification because there are other issues?
You can look through Embrace. Each of those dots is identifiable. You can often see that the babies where the congenital anomalies are born with cardiac defects are towards that.
And where do we sit if we just looked at that group of 9?
We would still be within that cohort that I presented on that second slide. So we would still be.
Yeah. Okay. And I suppose the same question I asked Lynn a year ago. Is there anything else that we could or should be doing here that you think of that would help us further?
Improving population health. These data are linked to individual organisations, but we know that the drivers of infant mortality, which is in the first year of life, are determined by population health. So if we can improve population health, women accessing services before they're pregnant, when they're planning a pregnancy, when they're pregnant, healthy diets, exercise, all of that stuff, smoking. If we could do all of that, that's what we'll see the biggest impact.
And I've seen you present before some of the great work that we do in an neonatal perspective in terms of collaborating with units from all across the globe and stuff as well. And I think there's been, from what I've seen anyway, they seem to be learning as much from us as we're learning from them. So that it feels like, as you say, there's such a lot of work going on in the QI space, the relationships with units across the there wasn't a lot more I could think of that we aren't really doing. On the population health bit, and this might be inaccurate, but we were just having the conversation the other day about it. For example, we haven't got a cure team at the women's, have we? So, one of the most effective interventions at stopping smoking that exists in NHS history that's been evaluated doesn't exist at women's, but does at Loft. Where's that on the commissioning plan?
Yeah.
There's some other things here, isn't there, around that population health that we really need to start from.
Got Mike, then Jackie, then Jim.
Thanks, Chris. That was really very helpful. This may be a question to the criticism. I think that the communication seemed to be a bit smoothed out to me. I think there's a more positive story to tell around where we are in the quality of care that we've provided. I think it's sort of the stuff that came through the bulletin yesterday seemed more a kind of a brushing off. That's not a huge amount to see here if you really understand that thing. Whereas I think there's a much more positive story to tell after what you've been saying. Maybe we can get more front-footed about telling the positive story rather than the nothing to see here story.
Thank you. Jackie, next, please.
Yes, so I know we had many robust discussions around the justification of taking out congenital abnormality because it makes you look okay, and actually was there any real issues in there? And I know we really challenged you about that to provide that evidence, but we have seen that stillbirth rate come down, and what you've described for 2024 data is looking really positive. We also invited St Mary's in as well to have a look, which wasn't on there.
That was the Northwest ODN. It was St Mary's.
That the ODN, right? Okay, because I think that was really important to us because St Mary's at that time was looking much more positive than we were. So I just suppose for me it is like Mike was saying, there is some really positive stuff here, but we can't just be seen to be trying to justify things through that. It is about still improving that patient safety around this agenda. So I just wondered through our patient safety work, what we could do a bit more about, because I think we go and have a look and we do the look and see, and we've heard from Di around perinatal dashboard that we've had some challenging times in the last month or so. So what else we could do?
Yeah, I think so. Congenital anomaly thing is interesting because if you look for the hospital that looks after the babies after they're delivered, they're not in the embrace data because it's only about place of delivery. So I've started conversations with the medical director at Alder Hay around ownership of these data, not just being Liverpool Women's, but being the LNP and Alder Hay, because the outcome data for babies with congenital anomalies is not solely, partially dependent on Liverpool Women's. The majority of that is dependent on care they receive after they're transferred elsewhere. So I think my role is first of all to get this cited on that Alder Hay, and for us together as the LNP to start looking at how can we develop action plans around the congenital anomalies. Is it something we could do better for those babies? The numbers are small, but they do have a high risk of mortality.
I'm going down Jim, then Chris.
Thank you, Chris. It is very detailed, isn't it? It made me anxious about me needing to present that. So I'm very glad that Chris did it. I'm frustrated by the quintile categorisation rather than decile. And if the board's in agreement, I'd like to take up that course because I think it misrepresents Liverpool in particular, and we should at least have an explanation of what happens. It isn't difficult to put the data into decile. Quite a big difference. So I'd like to pursue that. If I may ask one question of Chris, which is really whether it's difficult to define congenital abnormalities in this data set. Is it easy to categorise that?
Yeah, I think,
or are we constantly debating really who's in and who isn't?
No, it's relative. It's all done data analysis or data. I think the difficulty is a congenital anomaly can be you have a small extra digit on your hand through to a non-survivable cardiac defect, and all of them together data analysis. So thanks.
And Chris.
Thanks, Chair. Part comment and an answer to Mike's question as well. Oh, exceptionally helpful and insightful presentation. I think you touched on it at the beginning as well. Obviously, we've had media coverage recently around this story, and I think it is obviously not got into complexity of that, but it is presented in a very perfunctory way around red dots and amber dots, and I think the description today is really, really helpful. I suppose part of my question was equally about the type of media coverage in that very simplistic form about impact on colleagues, because again, and it kind of touches on your point, Mike, it was very therefore whether it's good or bad, understanding complexity and quality. So understanding about impact on colleagues working in those teams be reported in that way. But equally, this one might be a bit more difficult. But as we know, when stories are reported in media, it then tends to generate either a view of an organisation or a lot more questions from patients or families. And we've kind of touched on some of the behavioural stuff in other areas of the organisation as well. So I just don't know whether you could comment on that. And then to Mike's point, from my professional point of view, I completely agree. I think that this kind of presentation in terms of how we would not necessarily respond in a statement, but certainly how you will manage, I think, a conversation with a journalist about presentation of information in their report, and that it's not as simplistic, this kind of detail. I'm sure they won't want the 15 minutes of their life taken up, and I'm quite happy taking them through this presentation, because it's really important. Ultimately, it's about how do we maintain trust and confidence in services, and actually just a red dot or amber dot isn't helpful to patients and families. We need to fully understand the complexity of this. So completely take point. I'll be taking away a copy of the presentation, and I'll share with the team about how we manage those types of meeting inquiries going forward based on some of this detail.
Okay, we've got Peter then, David.
Yeah, thanks, Chris. Really good presentation and complex stuff as you said. But I think my head is where others have gone, James and Jackie in particular, and that congenital abnormality thing. I think, you know, I can see you take that out, you go amber, and the population health stuff probably affects that group more than anything else, doesn't it? So then you sort of think, well, what can we do with that congenital based use? Yeah, sure, I get that. We sort of answered that question, I think, when Jackie was probing, sort of saying, well, we can have conversations with others also involved in that care. But is there anything specific? Because it's quite a variable definition of congenital abnormality, isn't there? So is there specifics that we need to think about when we go into those conversations with partners about what we could do, what's there for some of those cases I do?
Yes, and every baby who dies gets an independent AMRT review that has an external patient on it. So we do learn from all of those tests. I don't. For me, the biggest focus really ought to be on the preterm infants. That's where the majority of the mortality is, and that links to maternal care, antenatal care, in labour, and perinatal optimisation. And I think that's where we really, that's where we'll get biggest bang for the buck, because some of these babies with congenital anomalies, even with absolutely perfect care, 100% of the time, will have a chance of not surviving. If we take a baby whose bowels are in the chest when they're born, and so I think the congenital anomaly bit is important, but if we want to shift the dial on our mortality, it's focusing on perinatal mortality, because we know 2/3 of our neonatal deaths will be in that space. And that's what some of this preterm optimization. I think I just don't want it to come across that we are dismissive of these data in any way, because these have driven a lot of our actions that we have taken to explore the data further and to do things to improve the data. So I just think we're cognizant of the intricacies of the data that the red. That's what makes it.
That's improved it.
Yeah, absolutely.
Thank you, and David.
Thank you. Thank you, Chris. Really interesting presentation and explaining the complexities of the numbers. You mentioned that in the past you've done some links with areas and somewhere else to compare our data. Have you thought about doing something with one of these soft southern hospitals that come up as green on the reporting, just to see whether there are any differences that we could learn from, and maybe they could learn from us?
We haven't at the clinical level, but at that research level, the University of Liverpool work is looking at the patient demographics within, so we will be able to see whether or not the population that we serve, are they similar across these organisations. So when we're benchmarked and they adjust at the 20% level, is that the correct thing to do, or actually is our 24 week very different to one done in Oxford? I mean, it's quite a small community as well, neonatology, so there is a lot of cross learning and so on, and we follow all of the evidence-based practice we can do. I actually think there's a big thing which is very difficult to measure around culture and around the culture of the care you want to provide. For those of us who've worked in intensive care for life, if we want to, with a lot of medication, the question is that the right thing to do? And I think shifting the dial we've seen in the last year is a change in our approach and that culture. And we certainly have seen that if one of our old NEDs, Louise Kenny, was on, she would tell you around the difference in culture between organisations who try and keep alive for as long as possible versus maybe make a decision early on about. It's very complicated.
One last word, Jenny.
Thank you. Thanks, Chris. Really clear. And you just mentioned about not being dismissive about any of this. And I think it's just a reminder really for us as a board, as well as we can explain it. And there are some really positive stories. Is just to remain curious in this area and just keep on top and make sure that we're sustaining that understanding of the data and the drivers for it. I'd encourage that.
Thank you. Very good presentation. Chris, very important, very timely that we have this discussion now after the embrace stuff. There's also, by the way, has been picked up in some of the discussion after the presentation. You know, precision in all of this is really important in terms of our understanding. And Chris Maudsley will pick this up, I'm sure, in the comms. Now, when you say our board's a mix of glass half full and glass half empty type of folks, and the classic example is when you say we're within 5% of the average after congenital anomalies are removed out, people think 5%, a lot. And other people think, well, that's there's a sense of reassurance that we're somewhere in the pack. So I think when we do the wider communication, that level of precision about assurance of where we are is really important. Well done. Thank you for coming along. Marine time management job this morning. So we're now going to take our break, and we'll absolutely. We're not wasting time. It's been important. We're now going to take the break, and then we will have a relentless focus on the core issues in the subsequent presentations.
Yeah, the LCL board meeting from last week, the 27th of March. The report there is read, Chair, but I'll highlight a few things. In terms of our risks of 10 and above, about 12 all have mitigation plans, but unfortunately, there is one that we have increased to a 12. I'll dwell on a little bit, give some more context, and that is risk 8522. We have failed here in terms of potential industrial relations and industrial action. A ballot for industrial action has been initiated. We received on the 25th of March night. It concerns the microbiology area, which affects 38 staff, reminding us that our population is establishment for LCL is 710. So, but nevertheless, it's a specific area. The ballot closes on the 15th of April, and post validation, then we need to get 14 days, depending on the outcome, 14 days minimum of notice if action was to be taken, and that would be taken anytime 6. So, the worst case scenario, May would be a potential for some action start in May. We are obviously continuing, though, to discuss with Unite, and we would hope to avert this core, and we continue to have those constructive conversations, albeit and doing some additional actions as well. I'll just list a few of those to give some insight. We do have a task and finish group with the microbiology team members. That includes managers, staff, and union representatives. It meets monthly, reports into the HMB, and there's been some constructive conversations there, sharing staffing reports, sharing comparator reports with other organisations, and indeed in the latest meeting this month, they agreed between them to move round some establishment and to increase lab assistants by a further 3 whole family. We also have taken the microbiology staff on a tour of other sites to see the complexities already in comparable work conditions, and visited Wirral, Mersey West Lancs and Warrington NHS trusts, and our understanding was that was well received and good feedback. We have initiated an external review of the staffing data, and that's with the Chief Officer of Rolling Care Alliance Pharmacy and Laboratories, and hopefully we'll get a first feedback by the end of this week or early next week. We've initiated the Allocate e-roster platform, and that went live on the 1st of April, and that will enable us to more transparently and specifically manage the rosters and the planning around in microbiology. We've also run on Friday a value stream analysis with our key supplier to see are there other efficiencies we can identify in this area to make people's lives easier and more efficient and effective. So all these things are continuing. We've also are about to write to Unite, further emphasising our desire to continue dialogue, and write to employees to let them know the things that are actively happening. But nevertheless, we also prepare for worst case scenario. So we're designing and have designed a mitigations plan, a contingency plan should strike action happen. And we've also had discussions with colleagues at MWL who had similar industrial actions that's 9 months ago, and we've got some learnings from what went on there. So it's really disappointing that this course of action has been taken, but we do think we are really being proactive. And if you look at some of the softer metrics, and you've seen in the IPR as well, around staffing, appraisals, mandatory training, they're all good, and we continue to focus on them through the culture. So really sad to report that we're at this position, but we'll continue to try and avoid if possible, but mitigate if necessary. Couple of other points just to note. We do have another 2 task and finish groups. They've been really effective in reporting up to the Hospital Management Board, taking specific issues. One on IT training in the chemistry area that has virtually come to a completion. Everyone's been retrained, had some really good feedback, so that will be stood down. And in the histology area, where we've been looking at ventilation issues, again, really good work with states and facilities to improve that environment, including some new kit that's on its way. Couple of other points just to note. The histology and cancer continues to be a real pressure area for us for the demand and capacity. We have had some improvements in process workflow, and there was previously a business case that was unaffordable, but we're revising that now in light of the new processes that we've put in place. Another area of a pinch point is around the turnaround times in the ED department. We talked about this before. We have deployed now the new analyzer in February 25. There are new rapid clotting tubes that the team are working with, and a new workforce process. And we think that those improvements will be seen in March, with an expectation that we hit target by April, which is really positive. Finance continues to be strong, and we're ahead of plan by £650,000, and we'll end the year ahead of plan. CIP achieved at month 11 of just under 4 million. Again, slightly better than plan. We received a board effectiveness review and got a clean bill of health, I'm pleased to say. And we also, importantly, received the management board closed down report, as many tears were shed, whether they were happiness or sadness, I'm not sure, amongst the team, but it was my last LCL management board. We'll be moving into the diagnostic treatment centre collaborative that Beth will take forward. Beth joins us for the final LCL HMB. Other than that, just to note, estates and facilities did a really good job. We've been working on this for about a year. They've opened the court. If anyone's been over to the Royal and the CSSB, there was a courtyard that was unused, and we've actually opened that up now. So it's a good facility for the staff. So their lunch is out there in the beautiful weather. Staff survey was, I know we're talking about it later on, it was reviewed at HMB as well, and results are disappointing, although it's really clear if we go into the detail analysis, there are two areas that are affecting LCL score, one being microbiology and the other being phlebotomy. Phlebotomy have legitimate concerns in the sense of we went and visited them over a year ago now in terms of trying to improve their environment and the waiting area. And unfortunately, that piece of estates work got consumed in a wider piece of estates work on that floor. And so they feel really aggrieved that we've not moved fast enough. What we are doing is going to initiate a task and finish group with that group of staff so we can get really specific and adopt what we think has been a successful process in other areas. They're happy to take any questions, Chair.
Thank you. There we go, Jackie, then David, please.
So it's just around the staff survey, if I may. So you've described how we're looking to improve staff culture and morale, but some areas have decreased from last year. I just wondered what support you're getting around organisational development to help with these staff, because they are very they're fundamental to the hospital, but they sometimes can see themselves as back office type workers, and they're not as visible as others. So how do you get in there? It's not the first time I've seen this in this group of staff, but you have to really focus OD on them as well.
We do, and we've had great support from Pip and her team. I think it's fair to say that from over a year now, we've started to try and understand the cultural issues, and there's also this tension between management and some of the staff areas. So we've gone back to basics with some really clear OD plans on that. But I think actually when we have looked into it, is these two specific groups of staff which in and of themselves are really valued staff, but are really aggrieved and agitated, and actually as a proportion of the people who respond, they definitely do and definitely tell us their feelings. So I think we're going to try and focus on that. But we have had OD support, and we've got a kind of progressive plan with OD.
So for the phlebotomist then, in raising a good task and finish group, had a meeting a year ago and perhaps raised some expectations that didn't deliver.
Yeah.
So I suppose I'm just interested that they don't get disenfranchised this time if some of that stuff can't be delivered quickly.
Well, exactly. There were actually, going into a bit more detail, there were two things they were really aggrieved about. One was the environment, because if you go through the front door at the Royal, you'll see that there's a waiting area there, which is kind of not particularly great. And there's a bit of a desk that people have to go in and book and say they've arrived and then get hauled round the other side to go and see the phlebotomist. That's the bit of a state we were trying to solve. We've not done, but there is now a design plan to do that. The other bit though, there was no booking system. So people didn't have a booking, they couldn't book online. So actually everybody turned up on a Monday morning, which created huge queues, and no one was there on a Friday afternoon, which was inefficient as well. We've now procured a booking system that will go live in the next month or so. So that should be a bit of a step to show we are actually trying to fix it.
David, next, please.
Thank you. If you're moving the phlebotomist from that area just as you go in the Royal door, I know the Charitable Funds Committee would like to put a charity office there.
I don't think I said it. We were moving them, but we're going to try. Sorry, Chris.
Really good to hear that the analyzer is being deployed in the ED to fix this consistently failing report that we've had for many, many months. When would you expect the impact of that to be felt, and when are we starting to consistently pass?
Well, in terms of the ED improvements, we're going to expect that should start to see that in March data, and the team have set themselves a stretch target, 50 target by April.
Thank you.
Tom, quick question about histopathology. So when I look at the report on number of cases of histopathology cancer cases reported in 7 days, it's about 50% of the total. So is there a clinical risk in this, and how are we managing it?
Well, we have John Brennan, who's Deputy Medical Director, is the acting medical director at LCL. He sits on our HMB and has looked into this area. I believe there is no substantial clinical risk there. We are, as we talked about before, looking at all options around this area, including a potential relocation. So he's going through a business case process.
Okay. Jim? Sorry, Jim.
I'll go after Jeffrey.
Interesting, because on the figures in terms of retention, it's a really high retention rate. I've managed technical people before in terms of that, and it's a different experience because often they're highly intelligent, sometimes on the spectrum in terms of that low emotion intelligence. So my question around the OD is, I get into the feelings issue. How does it feel to work here?
Well, you answer this,
I will.
I mean, if I want to pick up in a closed session, because these are really tricky stuff to do in OD, but it is at the heart often of what gets people.
Yeah, I mean, so I think where we focus is trying to make the environment as good as it can be, the physical environment, trying to ensure that people feel they have a voice and are communicated to regularly. Initially, we had an issue with the split sites that some of the Aintree lab folks felt a little bit isolated, and similarly, Broad Green staff. We've been out and had a managerial presence there so that they feel more engaged. I think that's worked well. But we have regular communication sessions with the staff, and we need to be doing more of it. Again, with Pip's help, we are trying to get into any nuances.
We've done these things previously. I think is if you can unlock the emotion.
Yeah,
it's what turned the dial.
Yes.
All the other things are kind of transactional. It's really getting to the emotional stuff.
Yeah, and I think some of the Ask and Finish group were actually, because I think in terms of emotion, trust is an emotion, isn't it? And trying to build a trust between certain sections of the management and certain sections of the staff is really important. Why we've tried to get into the specific issues and try and resolve those. Yes.
Thank you, Jeffrey. Right, let's talk Royal.
If you don't, all I just wanted to put on record, thanks to Rob for chairing the management board at LCF about 18 months, I would imagine. Because despite the ongoing challenges with some of the stuff, there has been a significant shift in stuff done, some good delivery. Yeah, I think it's been a successful year or so. We just got to get these last few things over the line in terms of the promises that have been made to staff. So I just want to
do that. Thank you. So I was moving on to the Royal. Absolutely.
Yeah. So there were two items discussed in addition to the normal risk register. So we obviously referenced that we'd received the CQC draft report. It was just to say really in that it was much improved, and when I've read the report in detail, we were really pleased with it as a site. I think it accurately reflects how it feels in the emergency department. Two areas that are noted in the report for consideration of improvement are continuing to improve the flow and access throughout the hospital, which obviously we talk about and will be a key part of our transformation plan going forward. And the other was just some IPC limitations that were noted around when we're providing corridor care, but we are already on with those actions with additional sinks, etc., being put in the department. So they were the main things for learning. We reviewed our staff survey results as well at the Royal. We were really pleased when we went through it. Against all 9 people promised domains, the Royal has shown improvement from last year. So I think with the context and the financial context we were working in, it felt like that was a positive result for the Royal. From a financial perspective, went through the finances in detail. We're reporting a 9.1 million overspend year to date compared to plan. Within that, we have a £12 million shortfall year to date on our CIP. So very similar to previous months' trends in that our underlying I&E is pretty much balanced. It is the shortfall in delivering the CIP programme that is our issue. We are forecasting a delivery of £25 million CIP, of which 23 million is recurrent. So that has been our real focus. We reviewed at HMB our CIP plan, where we were up to for next year, and we have got the weekly governance in place to ensure that, as we discussed in the previous meeting, that by the end of April, we have our CIP schemes worked up, milestones in place, and the project management structures and oversight in place. Just moving on to performance, if I just split it into sections. So if I start with urgent and emergency care, as James said at the beginning, the stats in the Royal IPR are pretty consistent with the previous month in January. Where I would just touch on that, we touched on last time, didn't we, around the ICB support now, around looking at UEC, in particular the not meeting criteria to reside issue. What is different in our reports? We were declaring across all sites about 23 patients a week as a category 3 on discharge, new patients. That has dropped in the last 6 to 8 weeks to 7 patients a week now. So we have really dropped the amount of patients that we are saying need to go into long-term support. So that now means that the Royal, over 50% of my patients who don't meet criteria to reside are actually waiting to go home now, which is the shift we wanted to see. And I've been meeting with the ICB in the last week, and I'm hopeful that the programme we've been up is where we're going to work as a system and get some support to really focus on that home first pathway, which we will then put into our transformation plans going forward. From an elective performance perspective, we have seen, so from a 65-week wait perspective, there was 1 breach at the Royal that was in St Paul's. That patient has now been treated, and we have just over 340 patients over 52 weeks. So we're working with Beth's team around our trajectories, but strong elective performance. On the diagnostics, you'll remember in previous months it was the endoscopy department where we were struggling to meet the 6-week standard for diagnostics. We've seen a 3% improvement in month, and we are on trajectory to meet our improvement standard in endoscopy. And then just highlighting on the cancer performance, you'll see a significant drop on the 28-day faster diagnosis standard. Just to note, because of the lagging cancer reporting, that is January's performance. So that's in line with the risk I brought to the board around the breast cancer demand and capacity mismatch. That is now up above 80%, so much improved, and you'll see that reflected in the next month's IPR. So just highlighting on the risks, there are 15 risks of 12 and above. There are no new risks that we haven't brought to board previously. We've already touched on UEC and the mental health side of things, so I'll take any questions on those if there are any. There are 2 risks I am expecting to reduce now for next month. One is the DMO1 diagnostic standard, because we are meeting our trajectories. And the other is the risk in relation to the IPC concerns and the cleaning standards. We have now approved all vacancies to recruit domestic cover 7 till 7 across all ward areas. So once we've got the assurance that those people are in place, we will look to reduce that based on the fact that we've had improved cleaning standard audits. We've had recent positive place assessments, and our CDT cases have dropped now for a number of months. So we're proposing to reduce that score. Just updates on the other risks. There was a risk that's been on the last couple of months around a lack of consultants to support the emergency general surgery on call at the Royal site due to vacancies and sickness issues. And some of this is also driven by the concerns around the workload pressure with the way we run the on-call on the Royal site. We've had positive progress on that, working with the BMA, and the general all consultants are supportive of a trial that will start from June, where we will form a different on-call rota at the Royal for a 12-week period. So we're hopeful that's going to give us some good evidence then for a long-term change to the way we operate emergency surgery. There are risks on the risk register, you'll see still in relation to breast and urology. They are the long-standing risks around the fact that we use premium capacity to support those services, and we need sustainable recruitment plans for those. They will be work streams in our transformation plan. So next month, when we start reporting on our transformation board, you'll start to see what those long-term plans look like. That was all I was really going to pull out for the Royal. Happy to take any questions.
Thank you. Clear report. Point question. Tom, first, please.
I have one question to comment. It's around the antimicrobials given for sepsis.
Yeah.
And where the metric was changed about 3 months ago or so. We haven't got a full set of data. But there's a clear discrepancy between what's happening in the Royal and what's happening in Aintree in this. And I don't know whether that's down to small numbers of patients or whether things are being reported differently or what. But there's something different in the two sites. I don't know what it is. Something to look at. Maybe I'm sure you have an answer to hand.
If you don't mind, I will. You know, that's okay.
It's a good observation. I don't know the answer, but I've actually got a meeting with Justin tomorrow, who's the sepsis lead for Aintree, to try and get on the skin of that. There's some custom and practice, isn't there? But the formula's standard, so I don't understand it. I can't answer the question satisfactorily.
Thank you.
Just wanted to say, you know, really well done on your evidence around the staff survey. So to have improved that again and maintain it is really good. So I know it's a lot of hard work there. So thank you for that.
Thank you, Jackie. Mike?
Similar, really well done on the good in A&E, and they do back on for your head, but pass on thanks. Outstanding. Cool.
Yeah, we will. Once we get a formal notification, we'll celebrate with you.
Yeah, I'm still excited about getting all these letters by the end of April. Well, that mixture of excitement and trepidation. All the pass through the new people. Yeah. Okay. Thank you very much.
Broad Green, just really quickly. So 3 things to mention on Broad Green. There are no risks for 12 plus. It was the final, obviously, Broad Green HMB. So we did take a document through around the governance to give ourselves assurance that we had mapped all the reporting into the Royal and Broad Green going forward. On the IPR, the only thing to note was that it looked like there'd been an increase in nursing fill rates to above 100%. That is actually because we opened some escalation winter beds that weren't in the established rosters. So those beds have now closed. So we'll see those fill rates return, but it wasn't because we were overstaffing areas. And then the other thing, which was a really positive development actually, is we had a presentation brought to us around the skin and eye pathway, which has been trialled in dermatology. That has been trialled and only used for a Liverpool cohort of patients initially as part of that trial. We've seen really positive results around what that trial has done around the 28-day faster diagnosis standard. The proposal was to expand, continue that trial and now expand it so it will start to include the patients within Sefton and Knowsley as well. A really good presentation. It is self-funding, so we approve that and we will be expanding that trial, and the hope is that that will become, I think, a mainstream pathway now in dermatology across the country.
Thank you.
There's bulk budget balanced. So that for year end, we're forecasting break even. Yeah. It might not be once it's with the Royal next month, but.
What question, Broad Green? Thank you. I know. We give the obvious, when we get into new arrangements, it would be easy for the Broad Green issues, the good ones, to be crowded out with size and complexity. So even though we're coming together in one board, I think it's important that we keep a specific focus on them.
Yeah, and
Broad Green site issues.
We've specifically looked at in the management arrangements around physical presence on the site and how we're going to be overseeing that reporting. So I think that is a risk, but we're very mindful of it.
Thank you. Any other points? Okay, thank you. Let's move on.
Thank you, Chair. So I'll try and keep this as succinct as possible. So there is 12 risks currently scoring 12 and above on the Aintree high risk register. 2 of those are sitting at 13, which is the risks around critical care, which we have made some progress with the ICB, and hopefully that risk will come down next month. And then the risk around discharge, which I'll come back to. Two new risks. One is on the diagnostic 6-week standard, which is echocardiography for Aintree, and I'll come back to that in a second. And the second new risk is around recruitment of HR business partners. That risk will come down in a month because we are now recruiting to some assistance with the trust colleagues. I'm going to highlight a couple of things and then I'll take questions. So just to give you the Aintree view of where we are with urgent care, I think as James said early on, we are seeing a sustained position now really around that ambulance turnaround, 60-minute ambulance handovers. We were under 30 minutes for ambulance handover for the last 4 weeks, and which was so quite pleased with that. Also that time to treatment for the senior doctor is at 70%, which is a second above the upper control limit. So definitely something statistically significant in that. And I just wonder, is that the sepsis bit, Tom? But we can have a look at that later. Third, is it? Sorry, I missed it.
Yeah, no, you've got 3 above the control limit. That's
something definitely changing. And we've made those changes whilst at the same time taking a real effort to keep our bedded, our assessment areas from being bedded. And if you look over the last 1 or 2 weeks, we come in every morning now to assessment beds ready to go. And I think that's going to make a real difference. So that's sort of part 2. Part 1 was let's get the front door sorted. The second part now is really as Nat has pointed out, the same issue with the Aintree risk sits around urgent care is the discharge and the complexity of that. Having said that, there's potentially some green shoots beginning to develop now, because we are seeing, if you look at the last week on the SBC chart, a run of 7 days running where we're below the mean on long length of stay, particularly 21 days. And again, 60-day patients staying in the hospital longer than 60 days. That number has dropped in the last month below the lower statistical limits. So some potential movement there as well, which is good. And that says we're seeing a shift from patients who are waiting to go into residential or nursing care to those waiting to go home with social care input. And there's been a significant reduction in those pathway 3, the patients going to nursing homes, with also a reduction in the length of time to get you there, which is good. But we have seen the converse significant increase in patients waiting to go home with social care input and an increase in time to get there, which is where the proposal work is. So that's urgent care. In elective care, I think we've discussed the 65-week rate issue. We know we're back in the interest on discussions earlier. Just coming back to the 6-week diagnostic standard, the key issue there is echocardiography for Aintree. We put some extra capacity in place in January, but that hasn't had the impact I would have liked it to have had. So I'd ask for a further review of what we need to do. That's coming back to the Finance Performance meeting this month, and that links to risk 8645, the new risk. I just want to bring out faster diagnostic standards and the 2-week cancer wait. That's something that has changed for Aintree. That's not something we've had an issue with before. You can on the IPR see there has been a drop in performance in that area. That all links into head and neck and some very specific issues where we lost a clinic in some of our spokes in the region, and also a registrar clinic at the same time. So that double whammy is what's caused that drop. We've now got those clinics both back in place, and we are focusing on getting the high-risk patients through as quickly as we can. So we're hoping that risk will recover. There's been if you carry it forward to the 62-day cancer standard, which is when you get your treatment, there's been a slight drop, but not statistically significant. So we're monitoring that currently. Just going to raise a couple of issues that I raised last month. One was required pressure ulcers. As I said last month, we had seen in January and February a statistically significant increase in category 3 and 4 pressure ulcers, and that was up to 0.51 per 1,000 bed days. So we took a deep dive in that to look at what was driving that. We were seeing them in the long length of stay patients. That's not saying long length of stay is the cause, but we were seeing them in the patients who are waiting longer. And there has been some learning that's come out of that, which I've listed in the report, but specifically us working with the more corporate services around tissue viability and dietetics and some use of equipment as well. So some real learning come out of that. We've got an action plan in place, all focused around that. Happy to take questions on it. And I know David's doing some work corporately, which you might want to come back to. Or do you want to set now, David, maybe?
I'll let you finish and then I'll come back to that. That's okay.
And then also, again, I've got something on the report just around the the MRSA bacteremias that we've had, as I said last month, that mostly related to cannula and cannula management, and that's come out in the report. And we've now got something around education about how to utilise cannulas. That's really quite strongly when we looked into the problems, and we've got a plan for that. I'll be taking questions. The IPR mostly shows everything in normal cause variation, apart from the stuff that I've already raised. But just wanted to quick note to say sickness absence has now reduced slightly. So hopefully we're beginning to see some improvement. It's not statistically, but it's coming down slightly. In terms of the finances, currently 13.5 million worse than plan, which is an overspent position of 0.5 million year to date. Income is 10.1 million better than expected than planned year to date. Pay 9.4 million plan, mostly related to undelivered CIP, escalation areas and our sickness. CIP, another 2.7 million this month against the plan 3.9, taking us to year to date of 26.5 million, which is 7 million short of where we should be, forecasting 29 million by the end of the year, which would equate to a 7% CIP. And the recurrent position there is just short of 17 million. I'll pause there. It was a quick run through your my.
Thank you. Clear point question. Oh, David, you want to come?
Yeah, if I may, thank you. It really, I guess, the point I'm going to touch on now relates to hospital-acquired pressure ulcers, falls, and infection control. And whilst I'm bringing it up in the entry section, I think it relates across the whole of the organisation. Honest, I think for the past couple of years we've been really diligent in looking and understanding our numbers and the issues, and I think we've almost fallen into the trap of just keep measuring all the time but not doing anything fundamental about some of those lessons that we've learned. I think something that was mentioned earlier on about the corporate services, and I think there's an element of including a specialist nurse, or that's not the panacea. They should come in as a subject expert. So myself, the senior corporate and operational site nurses are meeting regularly. We've got our next time out a week tomorrow around how are we going to refocus the activities of my clinical services around. I'm going to use the word accountability, not in a punitive way, but around giving people the expectation that they should challenge when practice isn't as good as it should be, or when they are in a situation where they can't provide the care that they expect to be able to provide for whatever circumstances. Because all the issues that we see around lessons learned are things that come up every time we do a review of an incident. And so we know what the issues are. It's around people following practice. It's around people being curious about what else could we do. It's about the ward having a mechanism to identify who are the patients who are at the greatest risk on that shift to be able to provide appropriate support. And that's going to take us focusing our attention differently, not forgetting about the figures and the numbers, but really doing a lot more of that individual development with wards and our local leaders. The information that we provide in the IPR is really important, but I think that I'm going to really probably this will come out incorrectly or clumsily. I think sometimes when we see within normal variation, we almost feel as though that's okay. And we're not looking at what the number is and always as proactive as we should do. And we've measured ourselves again. We've measured our performance against ourselves for a number of years now. The opportunity to think about, so where do we fit in the wider community or across England, across the world, in our instance of patient harm. So we are going to introduce some benchmark information so we can have a better understanding of where we sit and then where we can learn from, but also where we can showcase some of the great stuff that we have done as well.
Thank you. I've got Jackie, then Mike, then Jeff.
So, First of all, David, thank you. That was really heartwarming to hear that, because you've answered a lot of the questions that I've been asking over a number of months, and to be able to see you put some trajectories against and improvement against some of those numbers would be really great. Pete, it's a thank you for you as well for putting a moderate assurance against that report that you received, because the fundamentals of best practice pathways have not been delivered there. And I know we talked about, you know, bring it out in the public last time was a really brave thing to do as well, recognising that we needed to move on. So it was thank you for that. And I suppose it comes down to that bit about, because it was there in NASA's report about infection prevention and control. It's not just about nurses, everybody's business, and it's how do we just regenerate, re-energize that sort of information, and everybody's able to challenge each other. So it was just to say thank you and thank you. Cheers.
Thanks, Jackie. Mike?
Thank you. Also very much welcome what David says, really happy. It's a very general, very obvious comment in a sense about the planning diagnosis standard, or the prompt from that is that we're working to very fine margins now in certain areas, and you really see the impact of a marginal reduction of capacity seems to have a disproportionate impact. And obviously that puts a premium on staff sickness management, staff absence management, but also I think us being able to discern, is this a systemic problem where we have the capacity is not being used correctly, versus is this, we've got the capacity so right sized that if you take out a bit of capacity, you just see the, it's a shorter term actually, but you're very fine margins.
If I just come back, really good point, Mike. And I think some of it is on those really hard pressed specialties, and ENT and max fax for entry is really one of those where the capacity and demand is really finely balanced. In fact, actually, we need to think differently about how we utilise our capacity to try and give ourselves some headroom. So you're absolutely right on that. And that's why that's in the transformation plan. I keep saying it, but that's why that's in my transformation plan for this year, because that's what we've really got to think different. It's fragile services around us, which is bang into it as well. So ENT is a recurring theme that I will be really happy with.
The feedback really. Bev and I paid a really positive visit to the Nerkefima surgical unit a couple of weeks ago. Talking to the staff, how did it feel to work here? They were really positive about the working environment, dealing with some quite challenging patients. But the bit that probably inspired us the most was a repurposed room where the healthcare assistant and two of the nurses had redesigned a room to stimulate both physically, mentally and emotionally patients who were delayed discharge living with dementia. And they got a home cinema, a tuck shop, they bought a grand piano, which is a beautiful piece of Victorian architecture. And just the passion that the healthcare assistant brought to that room was phenomenal, wasn't it, Bev? And the pride in which she spoke about what they were doing to minimise the effects of delayed discharge. And we talk about that as it's an abstract concept. I mean, the thing that struck me was she got out and bought Knickerbocker Glory glasses, because the patients often don't drink the insured drinks. So they were making it to Knickerbocker Glories. And they had cheese and biscuits and chocolate. They got a stack of videos, and it was fantastic to see. And we were very, very touched when we were about it. And again, the pride of the staff were there, and you should all be that's that culture. Very, very proud.
Excellent.
Just really briefly on that, I know time's precious, but that's probably why they're a platinum.
Indeed, we could see that.
You know, because that just showed that in when they did their presentation, in my one happy staff, happy patients, that absolutely translates. But also they felt like they could make these decisions, and I think that's what he's free up and
they spoke of that.
Well done, Peter. David.
Obviously, I haven't planted that point for Jeffrey to mention, but later on this afternoon we have our vacancy control panel. We've received funding from the charitable fund to employ 5 activity coordinators with our dementia team to work across the organisation to do exactly that thing that Jeffrey's mentioned on a much wider basis. So thank you for that endorsement, and I'll ask colleagues to remember that when we go through vacancy control later. And I will buy you biscuits and a kebab.
I did add to that conversation with the committee as well.
Yeah,
I knew I'd say.
Yeah,
great.
Thank you.
Thank you. We're very positive and good to hear that the charitable is spending some money. Thank you. Really good. Right, Tim. bring a lot of all this together for us in the improvement plan update, and then we'll go on to the plan.
Thank you, Chair. I'll try and keep this brief, as much of the content in the paper has previously been trailed in the Strategy and Partnerships Committee and in the hospital updates. So the paper focuses this period on the shift we're making, as Nat and Pete and Jen have already alluded to this thing we're calling the Group Transformation Plan, which is trying to drive two shifts in the financial year and onwards. One is the shift to hospital-led delivery rather than very large cross-cutting corporate programmes, recognising that's been a sort of key priority for us as an organisation and now as a group. And the second one is from performance improvement to transformation, and board will remember the strategy we've had for the last 2 years of stabilising the organisation, moving into performance improvement and then into transformation. And we'll see we have an outline of the scope included in the programme, and there is a mix of programmes that are continuing from this year that it's really important to continue with. So things like our urgent and emergency care and not meeting criteria to reside, medicine safety, things like the short to medium term isolated site risk within the women's, alongside those areas that hospitals have identified are these are the things that are really important to us to do. And the paper also confirms that we are looking to allocate additional resource, programme management and transformation reports down into the hospitals to help with that improvement. We have cost improvement plan delivery fully woven into that. So as part of the hospital transformation boards that have been established, we will be looking for those groups to really challenge themselves on where are we with CIP delivery. As Nat's mentioned, there is ongoing work now to really drill down into the risks that we still have with our CIP plan. And David, you and I exchanged emails about when I can come to the audit committee to bring assurance to that work that is ongoing. But that remains a key risk for the group transformation plan to really define those routes to cash in the CIP programmes. Finally, there is an ongoing work going on around close down of the phase 1 the Liverpool Women's Improvement Plan and the phase 2 of the Luft Improvement Plan, and that report will be brought to the May board next time to give assurance that either the work is completed, is being handed to business as usual, or it will be a new group transformation plan. We have a system oversight group on the 11th of April, where we will be looking at the remaining areas under the exit criteria. So that's for Luftis Finance and Medicines Management, and for Liverpool Women's Finance and Cancer Improvement. I won't go into those because they've already been in previous reports. I wasn't going to say much more than that, Chair, but happy to take any questions on the paper.
Much question.
Thank you, Chair. And I think it's a great report, and it shows progress being made, and hopefully we can demonstrate that we hit the ground running in the new financial year with these things. One point, I'm sorry, it's really picky. But you mentioned the summary of the works coming to the University Hospital Liverpool Group Audit Committee. Something we can't delegate, Daniel tells us, so it will have to come to the individual audit committees. And hopefully, maybe we can even have a combined audit committee to look at that to save you some time. But really looking forward to seeing that date and reviewing it. And thank you.
It's not like I have a paper on delegations later on in the agenda. Thank you for pointing out.
So thanks, Tim, for the paper. I suppose there's some really big changes this year as we move into that stabilisation and onto the sites. So real challenges around achieving improvement this year currently, and then the managing directors are going to get all the extra work and some delegated resources to that. I suppose I'm just interested from the managing directors, are you confident that you've got the headroom to be able to deal with this, because it's another big change, having just been through the delivery of this year. So I just would welcome your thoughts.
Natalie, Peter, or Jenny?
If I start, and then, so it's slightly different for Liverpool Women's in the fact that we have a lot delegated already. So our structures are set up in year one of the improvement plan, which will mirror how we're doing the transformation plan in year two, because we already had our own improvement board and our own CIP meetings. So the transition for us in terms of the governance and structure won't be particularly onerous. I think what we're just really mindful of as a hospital leadership team is the volume of resource as a smaller organisation in terms of delivery and how we prioritise the work streams to ensure that we do achieve what we need to achieve. But in terms of structure and change for us, we're getting more support from the TDU, so it's more around our own capacity to deliver on the priorities that we've got that we're working through at the moment.
Gerard?
Yeah, so it's a really good point, Jackie, and I'm planning to use the opportunity with this plan to push the leadership of this site further than beyond into the LT, into the care groups, so I get real ownership beyond my team. And we're taking some, I hope, relatively brave but sensible decisions around the ethical rows, so that they're not just the standard HLT leadership. It's people are right there with them, but it's like, so I'm getting some of my divisional teams and care group teams to lead some of this work, and I think I'll get better ownership and hopefully better delivery if I do it that way, and that way I can expand the bandwidth, if you like, of people who are really pushing that improvement agenda. So that's where I'm hoping to reach it. Tim's obviously allocated TDU resource and some ongoing discussions about what that looks like, but we're pretty much there now, and we'll utilise that team to the maximum.
Ongoing discussion about what that looks like. That sounds interesting.
It's just some specifics around who's best for.
Okay.
Nothing.
Okay.
Yeah, really similar to Pete. I think I've got confidence. I feel I've got really strong divisional leadership teams at the Royal, and I think they're delivering a lot. I think the risk is the pace of delivery, because the programmes, when we go through the CIB schemes, they need some significant change. They might involve consultation. There's quite a lot of detail. So that's going to be the main risk, Jackie, is the pace. But I think that's where the governance around the project delivery and the support Tim's giving us, we should identify very quickly if anything is off track and what extra support's needed to put into those programmes. So I think we've got the right mitigations in to try and manage that risk.
I think a couple of builds on that. I think one of the really useful factors is we've got a template for how this can work. We at the start of last year put the improvement plan and transformation delivery unit methodology into the Women's Hospital, and I think we've seen that over last year. So I think we know we've got a quite light governance model to put in, and we're doing that. I think I'm as confident as I have been to date around the alignment of improvement, transformation and CIP delivery, and the fact that the schemes we now have are absolutely identified by the hospitals themselves and under these leadership. And I think we've got a couple of other things we could look to gain confidence. If you look at things like the fundamentals of care and the dementia and delirium work, they were examples that were absolutely led by the service areas, but we put a small amount of program management in and transformation support, and that made a really big difference. So, and I think we're trying to be as, in identifying the programmes, it means we can be as strategic as we can be around allocating support for my team from a productivity basis. So I think we're in as good a place as we've been since the improvement plan's been running, but resourcing in this year that we're going to go into within the NHS will remain at one of our larger risks that we'll keep very close on.
Okay. Thank you. I think it would be good to talk about the sort of report for the audit committee on the past year. Of course, we'll do, everyone does a whole organised 2 annual report, statutory bodies. But I think if in that, Tim, I sense that in the improvement and transformation work, there's lots of good stuff happening across all the organisations and all of that. It would be a good place to land some of those real benefits that do this way of work. There's a bit of a baseline then as we devolve more of this into the 3 management boards to be able to see how we can get greater agility and greater pace. Very good. Let's move on. UHL Group Finance Monthly Report.
Thank you, Chair. As I mentioned at the beginning, month 11 is a strange month. We're actually reporting on month 11. We've closed down at the end of, reached the end of the financial year, but not quite closed down the books yet. So it's work in progress. So I'll be as succinct as I can and take questions. Chair. Month 11, the organisation were roughly was 1.7 away from plan, and Liverpool Women's 0.3 away from plan. Our forecast at the end of the year, which we actually reported to NHS in month 11, formally was for Liverpool Women's to hit plan, 11.6 million deficit at the end of the year, and for Luft to be 8.2 million away from plan with a 41 million deficit, which is a significant improvement from where we were previously. If you look at CIP as a component part of that, at month 11, Luft have delivered just under 84 million pounds, and are forecasting around about a 93 million pound CIP at the end of the year, of which the full year effect currently is around about pounds, which equates to over 5% of OPEX, which is higher than the overall Cheshire and Mersey average in terms of CIP. It's really good news. But Liverpool Women's has delivered 5.7 million year to date, forecasting just under 6, and full year recurrent effect 2.4. Cash improved both organisations, 31.6 million at Luft, 6.5 million at Liverpool Women's, and we won't need to. We avoided needing to draw down further support cash from NHS, and hopefully that that does continue into April and hopefully beyond. Capital is on plan to deliver in both organisations the plan at the end of the year. A couple of key points to note. The legal claim were we agreed a solution with NHS, and that was paid in well for Luft. That was good work. That significantly helped our cash. No criteria to reside remains a big issue, and we're focusing on that. And Mandy Nagra has now been appointed Chief System Delivery and Improvement Officer with the ICB, and it's going to be helping us with that solution. New hospital conversations continue with NHS, and as we went through last week, the plan for next year, or this year now, 25-26, was submitted to NHS. It was submitted at a significant improvement after deficit for funding of £12 million in Luft and £11.3 million deficits for Liverpool Women's Hospital. And as I say, the new, that was agreed by the ICB, but is now subject to national approval and final sign-off. In terms of the system position, the overall deficit for Cheshire and Mersey in year is likely to end up excluding deficit funding just under 200 million at this point in time. And next year, the control total set at 178 million deficit. Currently, the submitted plan is in excess of that, at around about 255, but that is being discussed and worked through. So happy to take any questions, Jim.
Thank you, Rob. Points, questions? David.
Could I just ask Rob, we've had confirmation about the new hospital It's not new hospital anymore, is it? You know what I mean? The Royal Hospital funding.
Yeah, no, we've not. We've continued to make submissions with obviously the ICB initially. They supported our view that this should be recurrently funded to NHSE, but that's part of the ongoing discussions with NHSE, and actually it's part of that gap between the Cheshire Mersey Control total and their submitted plan. So that's live as we speak.
Mike. Thank you. Thanks, Rob. I think really so much impressive stuff behind this. It's been a mixed narrative all the way through the year, hasn't it? Really good stuff, really challenging stuff. But I think to get to this position, really impressive. Seems to me there's a question there for where do we need to get to in the year end, and that's potentially competing thing. One is what's the audit reputation, and then what's the audit process. So wanting a clean audit process. It is complicated by huge balance sheet adjustments. Where are you sitting in terms of where you think we need to get to beyond the numbers that you've outlined here?
Well, we went through a robust exercise leading up to 11, but in month 11, because you'll recall, we weren't actually, whilst we were flagging an unmitigated risk forecast, we weren't actually allowed to submit. We did do that in month 11, and hence the 8.1 million variance for Luft was what's expected of us. Obviously, we'll try and do everything we can to improve that, and hopefully we see a little bit of improvement. But we will go through the audit process. We've got a good relationship now with I think in both sides. There are some things that remain that could be fed in, not least the site revaluation that we have trailed and agreed with both we're doing, with just some final numbers to be finalised by the valuers. That slightly stymied in year benefit because there's a nuance that nuance in the rules that if our depreciation reduces, NHSE takes income away from the system. So we've just got to balance that out. But we've trailed all the accounting policies and our processes through audit committee inside of Grant Thornton, which was a learning from a couple of years ago. I think that's going to help us. So 8.1 million, 41 million pounds deficit is what we're aiming for, and the expectation, if we can get something a little bit better than that, we will certainly. We also want to hit the ground running.
Yeah, I'm very disappointed with not hitting the planning. We've been off it since the very start. One of the questions I have, Rob, is it says that when it was clear we were off the plan, we had a mitigation plan in month 5. Started mitigation plan in month 5. But is there a lesson to learn that if we started mitigation in week 1 or month 2, that we would have got to a better place more quickly?
Well, I think there is. I mean, it's not unusual that you have a refocus, and I suppose the expectation is in setting budget that everyone lives within the budget that's been set and agreed. You know that things come left field and expectations come left field, not least winter pressures and demand and escalation beds, etc. So I think we've now got a culture and ownership at with our site models and hospital models that gives it that extra scrutiny. We are going to have a bit of a phasing in the plan, but it can't be. We're simply not allowed to have a huge hockey stick, so we're going to have to hit the ground running. I think just going back to remember where we are on plan. Unfortunately, we did have and relied on some improvements in no criteria to reside that equated to around about £12 million. And that's not happened. Now, that's not an excuse. I think there's multi-organisational work gone on. I think our metrics in hospital have significantly improved. However, we've not been able to get the folks out or get at this stage. So that was a system-led project where we bear the costs.
But as we discussed in the plan for this year, just started, we've not included that because we just can't rely on the other bits of the system to work.
Well, for the plan for this year, we have included that, but we've got the risk share, haven't we? So if you think about it, in the same scenario last year, if they'd risk shared it, we'd be at balance.
Yes.
So we have got it into next year with that 50% risk share at ish. So an 8 million underperformance would have been mitigated by the risk share. So it's just a frustration that once again we sort of had 9-point-something% CIP in the left end of things. And one item that was, you could argue material, 10% of CIP, we've done 90% of it without system support. The 10% that relied on system support didn't get delivered. We've mitigated a third of that ourselves through other actions, but with a risk share in place, we'd have been landing right on the head of a pin, wouldn't we? So for next year, at least we've got that guarantee now, because I wouldn't have been set to have it and farm it out.
And on, there's a chart, one of the reports on pay run rate, which is obviously going up, and it talks about the pay award. You're able to say, Rob, if you split the pay award out, that's the pay run rate on a like-for-like basis lower going into 25, 26 than it was going into 24, 20.
But Jen mentioned you might inquire on that. So my instinct was that it's more or less stable over the 2 years, and background, the guys have run the numbers. So if you look, it's complex because clearly the pay awards are different percentages for different workforces, and they were given at different times throughout both years. But for 23-24, to month 11, on a like-for-like basis, we spent 764.827 million. For 24-25, we spent 763.607. So virtually stable. And if you look in the report of the movement in our workforce numbers, probably tells that story. So a very slight improvement year on year, but more or less stable.
Within that time frame, we've insourced facilities.
Yes.
And got more beds up. Does that include premium pay or exclude it?
In total.
Outsourcing as well stops. That will make.
Yeah. Okay, we met, I remind board members, we met separately to discuss the issues in the plan for this year. We'll return to those when the music stops on all. Thank you. Emergency preparedness, resilience and response annual week.
Thank you, Chair. So you will see in the pack the annual report details the significant activities that have been undertaken in 24-25 in respect of our arrangements with 10 domains and consisting of standards. It details the annual report details the outcome of the activities, which is an improved compliance score for both Luft and Women's Hospital. Luft has now got a substantial compliance position. We've gone from 18% to 89% in terms of our score rating, and Women's, whilst received a non-compliance, they also have significantly improved from a 7% to 73% compliance against standards. I think the report captures the great work and efforts that have gone on across the corporate space and across the corporate team and also site teams. There has been one annual deep dive, which was in cyber security, which Matt and his team have developed an action plan. And we've also taken in various other ways of learning and identifying improvements, being the 3 incidents that have occurred in the year, the 2 exercises that we have undertaken, as well as the deep dive. So I am not going to say anything more. I will just finish by saying this is here to receive assurance that the activities undertaken to date have been the right and appropriate actions to deliver the improvements, which is evidenced by the outcome of the year's self-assessment. That has been supported by second line assurance, being the MIAA audit undertaken in 23-24, and also to note the priorities set out for 25-26, the improvements in the 4 remaining domains.
Thank you. Points, questions? David?
Thank you, Chair. And thanks for the report, Beth. It's really encouraging. Because of the timing and drafting and everything, it talks about the system-wide exercise Gabriel is going to take place in February. That's obviously passed now. Did that go well? Was that successful? The lessons to be learned from that?
Yes. So we have undertaken that exercise and we have taken lessons learned. They have been written up at the moment and that'll be incorporated in. It's just the time enough writing the report. That's all.
Thank you.
Thank you. Progress. Where does this report go? Does it go somewhere now for external scrutiny and assessment? Does it sit on the record?
There's not one you would.
So it goes to the ICB, so they will ask for a copy of the annual report as part of the process. So once it's been approved here, it'll go through.
So let's receive that as we want to send a fella out with a clipboard.
Well, they do actually come out with the clipboard there as part of the annual assessment, but that's later on in the year. We'll look at send this.
All right. Thank you. All good. Right, so we've got a suite of issues around equality, diversity, gender pay gap, and that survey. Are you going to take us through them?
Take all 3 of them, if that's okay.
Yeah,
Thank you, Chair. So the update to board this afternoon will cover 3 annual reports as part of the board side of business. And the board has been asked to receive the
Sorry, Chair, it's very difficult.
Sorry, I'll try. I don't normally have that problem, but I'll try and raise my voice a little bit. So, sorry, the board is asked to receive these papers as a combined update. The 3 reports all do focus on experience of our colleagues, hence the reason why we're bringing those together across UHLG, and also the factors that influence the level of positivity or negativity that is related to colleagues' working lives and experiences whilst in the organisation. So the reports you will see across all 3 of them provide both a look back on the work achieved and progress in 24-25 for assurance and oversight, and also will provide elements to support us to move forward and plan, using data and insight to inform plans and priorities for the coming years. The board is asked to note that hospitals are at different stages of their journey on improvement, particularly in the people field. And there are variances in the areas of priority, positive actions that are reflected in the report. Yeah. So it can be quite challenging just to bring all of these reports together because there are slight variances. Okay, so the 3 reports I'm going to take you through are the UHLG ED&I annual report, the annual gender pay gap report, and then finally just a high-level summary of the NHS National Staff Survey report. And Chair, if it's okay with you, I'm going to then summarise the collective ask to the board at the end.
Yeah.
Okay, so if colleagues, so I'll just provide some high-level context in relation to the ED&I annual report. The report that you have in front of you is for board approval. And it's a design version using approved text. There is going to be further work on that with support from Tom's team to actually before it gets published. So we've kept it in this format just for any feedback. So there is some finalisation work that still needs to be done. And colleagues will be aware that each year each trust needs to publish our equality, diversity and inclusion annual reports, and it provides an overview of the compliance with the public sector quality duty that we have as organisations. It also gives us an opportunity just to outline all the progress that we've had and all of the fantastic work that colleagues have contributed to over the past 12 months. It's definitely a collective effort within kind of the achievements that have been made in this kind of field across both Luft and Liverpool Women's Hospital. So you will see within the annual report that it outlines our key ED&I priorities, key achievements and highlights over the past 12 months. A really critical part of the success for us and moving forward will be our staff networks. So there's a particular part paying attention to staff networks and the work that the organisations are doing to tackle health inequalities. And it will also outline some of the priorities that we're looking towards next year. It also, I guess, the request just to note within the report, the board and colleagues around the table have committed to being active allies, to amplify voices and to drive meaningful change both within and outside of the hospital walls. And I guess we just wanted to collectively acknowledge the support and thank you for that. So just a summary of some of the key achievements, significant progress across this area. It should be noted that Liverpool Women's are slightly further on some areas of anti-racism and some areas of their priorities, likewise Luft is. So what we try to do is pull together some of the significant progress, of which there is a lot actually, and a lot to be recognised and celebrated. We now have ED&I objectives for all executive board members in place against protected characteristics. So we have huge sponsorship, that's recognised. We've had over 200 engagements with the anti-racism hub that is facilitated through Liverpool Women's Hospital currently, and staff are engaged with that. We've had over 90% again at Liverpool Women's as a key area of focus for them. 90% of staff have now completed face-to-face ED&I training, and we've achieved veterans aware status and won multiple awards for widening participation and encourage access outside of the NHS into the NHS through different talent pathways and attraction mechanisms and relationships. That's something really to be celebrated. We've also run a Cheshire Mersey Elevate Leadership Programme, which is aimed at supporting ethnic minority leadership colleagues to develop, to gain experience, and over 90 colleagues have been through that in the last year, and there's further commitment to do 2 more cohorts into next year, and to make sure that we kind of maintain that as a sustainable kind of development programme. And both organisations in September signed the National Sexual Safety Charter, which commits our zero tolerant approach to unwanted sexual behaviour within all of our organisations. So really, really critical as we get into the National Staff Survey and some of the feedback that's coming in around that. And then something, again, which we continue to kind of focus on into next year is the importance of the strategic partnerships in place to be able to develop and continue to develop these inclusion priorities. So significant relationships and development with Liverpool City Region, the Brain Charity, who are a local organisation, RASA, who are the rape and sexual assault organisation based in Merseyside. So I guess they are some of the significant achievements that we've had collectively, and it is a collective commitment from HLTs, from our executive colleagues within the organisation and outside of partners. So I think this work would be we wouldn't be able to do it without collective commitment. So that's something really important to notice. In particular, on the ED&I work, there is a harmonisation and review piece of work that's happening across broader organisations, across LASP and across Liverpool Women's and across Luft, what the current priorities will need to be. We know what most of them are going to be, but the sequence and prioritisation, and also the resource that we're going to allocate to them from a specialist perspective is a piece of work that's ongoing at the moment, just to ensure the success of the work and build on that into next year. So that is the summary of the ED&I annual report. They could just take a glass of breath. So the second report, just to take your attention to, is the gender pay gap report. Again, there is a national requirement for us to be able to submit and publish our data around that. And it's applicable to all organisations with over 250 employees, of which clearly we are. So both statutory bodies, so Liverpool University Hospitals and also Liverpool Women's Hospital, we need to publish our gender pay gap before the 4th of April, which is tomorrow. So we've got a day to be able to publish that with your feedback. And the report, I won't go into too much detail into the report because there's a lot in there and there's a lot of appendix, but I'm sure you will have had the opportunity to read through. But the appendices also bring together some of the key findings, some of the common themes and some of the common trends relating to pay challenges across gender. So some of the key headlines are our pay gap across both organisations is pretty similar, actually. It varies between 25 and 24% variance between male and female pay. At midpoint, men are paid higher, and that's kind of trending currently. That's kind of year on year. We're noticing that, but the gap has reduced at Luft and has increased at Liverpool Women. So again, the consistency to be able to report is a little bit challenging. There has been an increase in average hourly rate of pay for men and women from both organisations as of the 31st of March 2024, and specifically around. So for Liverpool Women's, there are no concerning representation gaps to note. And that I guess that basically means there are 4 quartiles up to kind of so from entry level banding right up to kind of very senior leaders. So for the women's, there are no concerning representation gaps from a female perspective. However, at Luft, we have seen a decrease in the representation of women in the top paying quartile. So again, just something for us to note and potentially be curious about and understand that a little bit further. So I would ask the board to note that closing the gender pay gap is very complex. There are multiple elements and facets and multiple things that we need to address. Multiple kind of cultural elements, processes, but we know that the recommendations that we've got within the report will help us to create those initial steps, basically, and a more holistic approach to be able to kind of drive a greater sense of accountability for improving the position as it currently is. So the recommendations, there are key 6 recommendations that you can see within the report. The first of which is a targeted mentoring programme for women. So again, a real positive for us within the organisation. We now have a very active female inspiring women's network with 50 plus members who are very keen to be the engine for momentum and action. So they will be key to us kind of sharing this report and identifying some areas of action as we move forward into the next 12 months to commit to. We're due to do a review on leavers just to understand the reason for leavers across every part of the quartile and understand potentially whether there is anything in relation to kind of childcare or access or development opportunities, so we can understand that further. And I think probably just 2 key elements, additional elements that we're going to look at are recruitment and attraction practices. So we are due to do some work organisationally on a recruitment values approach. So we have more of a values-based recruitment approach. But in addition to that, what we want to do alongside that is look at the policies and approaches and just sense check those for any gender segregation or any additional support or equity across specialties, so we can make sure that we're giving everybody the best opportunity to have representation from every gender across each of the roles that we have across the organisation. And then just further analysis around pay gaps by ethnicity, by diversity and disability and other protected characteristics. So a lot of work to be done that we've planned over the next kind of 12 months and onwards. And then finally, so staff survey, we've talked quite a lot about staff survey today. And staff survey took place across both of our organisations, both of the trust back in September to November. So again, I think Jake mentioned that from a Luft perspective, we've stabilised. We've actually seen an increase in 9 of the promise themes. So only marginal, so 0.01, which isn't statistically significant, but we've stabilised. It is important to recognise the context in which colleagues were completing that report. So the report was in September, kind of November time. We've heard about the increased financial scrutiny, the increased controls, kind of vacancy gaps, etc., which undoubtedly will have exacerbated colleague experience. So it's just important that we note that. What we are seeing, so from a Luft perspective, we have seen increases across 4 of the people promise themes and a stabilised position with incremental increases in engagement, but very, very marginal, so nothing statistically significant, but given the backdrop, that's pretty impressive really to maintain it. Liverpool Women's unfortunately have seen a slight descending trend in most themes, with the exception of an increase in We Work Flexibly. So I know the team have been doing significant work in that. So that's, I guess the other element just to kind of pull out of the report is we are really starting to realise the emerging benefit of us being at UHLG as a group, and the maturity of the leadership structures at sites and the responsibility and accountability and driving of some of these actions by exec MDs, directors of people being imposed and heads of people. So that really helps us centrally to make sure that we can drive those accountabilities. And yesterday we were able to confirm through staff brief the key areas of priority for each of the sites. There's a real responsibility on that, which means and we can really drive improvement and change, and we can look at it within a holistic approach. We can really start to look at divisions, different sites, and where we can make the biggest impact. So that's a real positive for us as we move forward with UHLG and other organisations. Just 2 or 3 points just to pull out from a love perspective from headlines. So we've seen an increase in confidence to raise concerns and that the organisation will act upon them. We've seen a 3-year increase on recommended as a place to work, and particularly for love, that's a 10% increase to 45%, which is significant for any amount of change that we've been through. We have, however, and this is a national position, and similar for Liverpool Women, seen an increase in burnout. So colleagues who are emotionally drained, colleagues who are physically drained at the end of a shift, colleagues who can't spend time with their family, we're seeing an increase in that. There's clearly some work for us to do to kind of ensure that we support colleagues, especially through the change that's going to happen over the coming 1 or 2 years. Pete, to your point, there was a decrease for us in particular, autonomy and control, people being able to influence the opportunities, being able to change ideas around them. So with vacancy controls, there is a feeling that there is less autonomy and control to be able to impact on those things. So again, it's something for us to pay attention to when we start to look at the opportunity of UHLG 2030 and organisations coming together. And then just finally, so Liverpool Women's have also seen an increase in their advocacy and recommending as a place to work, an increase to 63% year on year. So that's a fantastic achievement. Improvement in flexible working opportunities and a really significant, statistically significant reduction in colleagues experiencing discrimination based on backgrounds, a 20% reduction, which is significant. Obviously, all of the work, we can start to correlate the work that you've been doing around that, so that's fantastic. Some work to do potentially around declining recommending as a place to work, some of the burnout and energy levels that colleagues are feeling. And we start to see a slight spike in feeling safe to raise concerns about unsafe clinical practice. But I know you've got, as part of your improvement programme, a safety culture programme that hopefully we'll start to see the impact of that in the coming weeks and months. So that is the summary of each of the reports. I guess just to ask of the board then is to approve the content and publication of both the gender pay gap and the in line with our public sector equality duty. And finally, just to support the collective priority and recommendations that are included within the 3 reports.
Thanks, Liv. Thank you.
I think that's a really concise summary. I think it's an awful lot of funny and some really good things. I think it really kind of highlights, whilst individually the reports are really strong, there's a real correlation between them, relationship between the three. So things a lot to go at, particularly, for example, there's social factors, there's ethnicity, but also I think there's actually representation within roles, not just bands. So I think the key thing here is it's that data analysis, isn't it? Yeah, absolutely. The capability to do some more meaningful work. So I think that's just something that we need to look at moving forward. But I think really good.
I think there's a huge amount, isn't there, of capability building for us. In addition, I think as part of the national programme of work around the future of people and OD, there's a big investment in identifying what those core capability gaps are for the organisation. So it's good to work with you and get your experience as well from that. Thank you.
And Mike.
Thanks, Peter. Really well done. One minor point and one question. The minor point, so I support the EDI report. I was just surprised that the high-level summary, the order of the high-level summary, started with some really impactful actions that kind of get buried further down. How we started with those to try and say, look, we've made real impacts here rather than some of the high-level things. The question is, in terms of gender pay gap, I hear the point about unequal distribution and forming a pay gap. Are we absolutely confident that men and women doing the same job are being paid?
Equal pay.
Yeah.
Yeah, absolutely. So there's very different perspectives, isn't there? Kind of gender pay. There is, so we've literally just formed a report now, so there is a huge amount of work to do to go away and look at those things, and that's a key area of focus at all look at to make sure that we're assured.
Thank you. Pip, so we've got a number of networks now, which I think is a great way, to really focus on some of these really key issues. I suppose my ask is whether we can receive quarterly updates, because I am not cited on the progress throughout the year, so we don't need it all the time, but quarterly would be good. I'm participating in one, but not across all of them, so that would be good. So I suppose the second thing, and you might want to take this away and just think about it, but when you look at the corporate risk register, it doesn't really capture any of. Now you might say no, they're there, but they're of a lower risk rating. But the gender pay gap has been an issue now for 2 years and one thing, and I'm sure there's lots of actions being taken. But what risks do some of the things that we've just reported on pose, I suppose, and whether you are capturing it in a risk way, so we can keep track of the mitigations and that kind of the control. So it was just for you to go away and have a think. I don't know.
And absolutely will. Just I think, as we talked about, there's individual risk with each of these things. The collective risk is even bigger, isn't it, when we start to look at that and capture it. So there are risks kind of listed within the broad assurance framework generally, on kind of a broader topic, but not the specifics around some of the elements that we've just described here. Probably now that we've got the data,
yes.
Once we've done the data analysis, we can pull those out, see the appropriate place to put them, and the plans that go alongside it, and then we can provide assurance through those routes.
Got Jim then, Jackie.
Oh, thank you. Thank you, Pip. We've got 1,350 doctors now for whom we are the designated body. Is it going to be possible to get a subset analysis?
It is, Jim, yeah. And I've had the team working on that behind the scenes. The challenge that you've got is dental and doctors are combined because of the way in which it is reporting. But so I'm trying to get the team just to split that so we can give you the whole bit, separate sections, so that you can, and the verbatim comments as well. So you can see that we can help you look through it.
Thanks, Pip. Suite of 3 really important papers. I suppose I'd like to come back to the EDI annual report, because as a board, we have the high impact actions of our board objectives, and I don't see that they flow through here as probably as strongly as they could do, and how we demonstrate that to the public, that we as a board have got our own actions and that we are working towards those.
Perfect, thank you. I'll make an addition and just circulate it back around before we do it. Thank you, Jackie, that's really helpful.
Thank you. Go on, Jenny, your take on this, the staff survey scores. We have below average and below standard response rates across the piece. At Luft, we have a low staff engagement score, which is consistent with it. It seems to me there are 2 things we need to keep pressing on to try and get a broader and a deeper picture, but notwithstanding all of that, what's your take on?
Yeah, so we're pretty static in response rate, and the one thing that we're always cognizant of as well is our comparators in terms of specialist trusts, and a bulk of our services are not specialist, they're more DGH trusts, but I think we do struggle with high levels of engagement in the staff survey, I think, but the time point of view. But in terms of the results that have come back this year, as Pip says, those 2 that have been really encouraging, or one in particular is around the experience of discrimination, and I think that's just an absolute testament to the work that's gone on through the work that we've done through the anti-racism hub. There's more to do. There's always more to do. It's just how impactful we can be in terms of getting people to responses and feel able to find the time to do it.
Okay, thank you. So we're asked to approve all the reports of the gender pay gap. There's some specific actions which you've run through. So it's to endorse those actions and to improve publication of the report. We intend to do. Thank you very much. Well done, Pip. LQAs, please, David.
Thank you very much, Chair. So colleagues will see that the paper's presented in its usual format that most people have seen before. And just to remind people that the LQAs are award accreditation process that we have across the organisation, has been in place now for about 3 years. Whilst the report, I think, gives a great summary of some of the achievements within our organisation, how lot of wards are moving through, demonstrating assurance around compliance to the things that wards need to have in place to have a firm base for it improving. I would like to perhaps deviate from the actual report itself to talk about the future. We know that the LQA, when it was set up, is very much in the same model of a lot of assurance tools for wards and inpatient areas, and that was really based on a Care Quality Commission key lines of inquiry approach. That was the way in which we were all inspected, and that was the way that people would come in and they would have a whole series of things that they wanted to see, and a percentage of things that they wanted to see out of a whole visit, and then that would be supported by local data, and that I think that's worked so far. However, there's a number of things, or two things really, that have come to sort of mind around. Probably, well, we are going to revisit what the LQA is. We are going to stay with the LQA. However, because we've been immersed in inspections for the CQC for a period of months, we actually saw how different the inspection process and rationale that it now is. And they come in very much with the sense of doing an appreciative inquiry and then supporting and triangulating that with evidence. They will more often than not have this.
Oh, sorry.
That was the sequence with to tell. Burst in the bubble. There you go. No, take me. I'm delirious. So they will often have a person with specialist knowledge within their inspections that are focused particularly for those areas that they can go and look. And we tend not to do that, if I'm being honest. We have a group of nurses who carry it out across the whole of the organisation, so that we have, I'm sure that we have consistency, because they are the people that do those visits. However, I think it's time for us to change. And that's really been brought to light. We know that the tool is a bit of a catch-all, and that I don't think, or we are now seeing that actually for some areas we don't know whether it's got the subtlety to be able to pick up the nuances in particular areas, and that people are focusing on the tool rather than what they're actually seeing. What I really want colleagues to be aware of is we're not going to fix the tool so it just looks better in results. That is not what we're going to do. But we want to make sure it is a more sensitive and appropriate reflection of what's happening within clinical areas. And this has been, I guess, requested, but also supported by our colleagues from sites who have tried lots of different approaches for those areas that have stubbornly remained in red in particular areas. But actually, the performance in some of those areas is no different to some of the other areas in their patch that are looking more successful about patient outcomes. And so we've chosen to pause the LQA for a few months across the organisation. And during that pause, we are deploying those corporate nurses to sites to support those areas around some of those thorny issues that they're having problems with, so that they can support the ward staff and the ward leaders in a different way, but also perhaps to understand more around their role in support and quality improvement, rather than simply carrying out the measure. And so that's a piece of work that we're undertaking now. It ties in, I think, a little bit more to what I was talking earlier on around the NPR, around us needing perhaps better metrics to understand, and perhaps better metrics will mean less audit, because we awash with nurse-led audits across the organisation. But you know that measuring it's the action So I want us to accept the report for what it is. I think we have seen great movement. It is and represents a valuable tool to support staff on working together, really enhancing leadership at all levels on a ward and ownership on wards. And we've seen that on areas that have been mentioned today. What's out Ward 29 here, around people feeling they have knowing that they have the autonomy to make change. But that we are now in a place where I think we're at our next step for maturity as an organisation. I'm happy to take questions either on the report or my comments.
Thanks, David.
Just want to go back when we talk about LQA and the organisation, you're referring to Loft, David.
Sorry, yes.
Yeah, the women's has a.
They have. You'll have your own ward, and in time we will look at how they can become one. But at the moment, I don't think either of us are in the position to be able to do that.
Thanks, got Jackie then too.
So thanks for that, David, and I appreciate you get around to inquiring that. So probably following on from been said, then it's about how we do link in the quality standards are going to be different here. That will be the same across Liverpool Women's, because I don't want to see any differentials around these. So I think it's really important. But also in your LQA are some really important things, which about the must-dos. So your medicines management, CD checks, things like that. So you can't get rid of all of those because you want to be assured around it. So I suppose it's a development work you're doing about what you bring back afterwards. That shows that we're still delivering best practice, but absolutely looking at it in a different way, and it's not such a blunt tool.
Yeah, absolutely. And so just to give assurance, I don't think that the subject titles or the subject issues will differ. It'll just be perhaps which we carry out that review of practice in areas will look perhaps in a different way, and perhaps it's a greater depth and quality.
And Tim?
Yeah, thanks, David. Really useful report. I want to check I was reading data right, because it appears from an improvement perspective that we've got good wards, I think, getting better, but I counted something like 19 wards where they've got red inspection, then red inspection, and 95% of those of them are in medicine. So I guess there's a question around, is this just part of that an impact of site pressures, outlying patients, the pressures a modern hospital is under, or should we reasonably expect, even with that going on, a ward in a modern hospital to be able to still get LQA platinum? And if the answer to that's yes, I'd be a bit nervous about us pausing the inspection. I think it's about how we bring targeted support into those.
Before I bring that in, the pause is only for a couple of months.
I had exactly the same conversation with site director of nursing. So we've gone through and looked at those that are consistently red. What are the other metrics? So what are the pressure ulcers like? What's the complaints levels like? Acute medical unit at the Royal concerns me. It's consistently red. It's flagged on various metrics. So that is going to still be monitored. We're going to have a separate, through our urgent emergency care improvement programme, we're going to have a quality improvement thing around the AMU, and we've changed nursing leadership on there, strengthened it, etc. So we've sort of done that sense check. So I'm comfortable that while it's paused, we've got the oversight of the other areas, but the one that I'm concerned about, we're going to be putting some additional support into.
Thank you.
Yeah, thank you. And thanks for explaining the process, David. I understand it's paused while you're looking at it again. But what sort of support do the wards get when they come up as red? The report says that one of the wards at Aintree was last inspected in May 23, and that was scored red again, and it's scoring lots of red there. Is there some targeted work with that ward to see how it might improve?
Yes, indeed, and there is a local improvement plan that's developed with the ward and the matron of that area that is managed and supported by corporate services for particular issues, but is overseen by the site director of nursing. However, then we need to have a different approach for what that support looks like, I think. and that we've got some very clear themes across the whole of the organisation. We know that breath falls, nutrition, hydration, just to name three of those fundamental aspects, are concerns that we're not seeing a turn of the dial again to make it look as though we're making improvements. And it's unsurprising that those areas that have been mentioned are the areas that have more dependent patients with higher acuity, that are on there. And so we need to focus what do we need to do to support the staff on the wards to make that quality improvement? Because what we've been doing now has been okay to a degree, but it's not really making a significant difference.
So you can assure us that something has happened since May 20.
Absolutely. Those wards locally have received support and supervision.
Thank you.
Okay.
So I'm very supportive of this initiative. I think it's very timely. I've always been slightly concerned about us marking our own homework in this regard, and I wonder, is there any external validation we can bring into a new tool that we haven't done quite so far?
Yes, I'm sure there is, because I'm sure that other organisations and board accreditation processes are sort of almost universal now, that we could buddy up with another organisation so that we could peer review or just experience.
Okay, thank you. We intend to approve the way forward. Well done, David. And you'll come back to us after the pause period with them.
Indeed.
Right, now we have a suite of papers around the development of LASP and the group, and a bit of filling in the governance between our two statutory bodies that we have here that we cover. Most of this we've seen one way before, but I'll come to James first, Tim, to set all of that up.
Yeah, sure. So we've just, in terms of the process here, there's a case for change document that the board has already seen before. It hasn't changed materially. There's a presentation included in the back, which myself and Tim gave to the ICB board last week. The ICB board has approved case for change. The ask today is for this board to approve the case for change. That's the first bit. And then in the UHL group governance, there is a suite of stuff that is aimed at helping you get to sleep, I think, in the evening. But if you've read it, well done. And basically that describes the delegated functions that the board can delegate to the local committee. That's been discussed and approved by delegation through the chair and chief executive. So it's already been delegated, but it's there for noting today. So in summary, really, I think you've seen the case for change. The presentation is there for information about what we gave to the ICB, and then the surrounding UHL group governance reports, which give you a flavour of what's been delegated to the joint committee now for note.
Thank you. Thank you. Points, please. This is really important. We've seen it before. Don't need to go over the old ground, but this is really, really important point in our development of new ways of working across the city. So, any concerns? Down, David.
Could we have some understanding of the time frame for resolving or clarifying the issues around financial delegation, which are left open?
So I guess for clarity, the delegations have been approved by the joint committee. So the proposals for those delegations are in place. The advice from Brown Jacobs, we need to clarify how we get appropriate oversight, both as a last joint committee and within individual trust boards, so we know what trust boards should be focusing on, what we do collectively. It's fine. The vehicle that joint committee has put in place to do that is a finance committee, which will have NED representation and direct finance representation. That should be in place in April. We're hoping that early May, and the first order of business for that will be to just really fine tune what that oversight looks like. I don't know whether James or Rob you'd want to.
I think that was it. We didn't feel in the joint committee we should give assurance on behalf of the together yet. as to whether it feels assured, if that makes sense.
Yeah.
That'll follow now.
That'll follow on. And in the recommendations, it says to approve the delegation set out in 2.3 below. And I've read the report many times to try and find 2.3 below, and there ain't one. So presumably that will come back when the Finance Committee has clarified the arrangement.
Yes, it's the same. She was.
Right, thank you.
And Mike?
Thank you. So very strong support. I think in terms of our own diligence, there's a technical delegation, there's a cultural delegation, isn't there? So technical delegation is well expressed through these. The cultural delegation, maybe this is just the scars of that committee peak we are. How do we ensure that it is progressing? Because we are delegating a lot here. And how do we ensure that it's making the right kind of anticipated progress in the right kind of way, and that's formally reported back so that we can keep control over the aspects of our own life that are still we are responsible for.
Well, yeah, I think you come in, Jane, but I think for us, it's slightly different for us in these the Liverpool Women's loved and now for the group, because as chair and chief executive, we delegate it to ourselves. Therefore, it's our responsibility to go back to what would now be the three statutory bodies, two in this group, and the Heart and Chest Secretary, give the necessary assurance to other board members about those things. And it's I'm not saying, don't worry, it's all going to be fine, because we'll get that. We'll need to work through them together. But I'm very aware as chair about responsibilities in making sure that happens, so that we're not sat in this board with folks, hang on a minute, where did that, and that affects us, and that's our responsibility. So we'll work through all of that really carefully with the boards.
And the audit chairs as the members of that finance committee from the 5 organisations, again, provide the level of scrutiny and independence to a degree that should give us confidence. So that the planning audit chair will then obviously go back to boards with a clear update report.
Yes,
just final build on that last point. So just wanted to make the connection with the sort of group transformation plan that came earlier, because one of the pillars within that is the last programme. So that's the 8 programmes that are designed to deliver the work of the last joint committee. And these delegations are designed to make those programmes be able to deliver. So the last programme will get very strong partners back in the same way the improvement plan does now. So you should get much better granularity in reporting on this agenda than we've had previously.
Yes, David.
Could I just add, just picking on Tim's point, James' point there, that it's really important that we close that circle, because as James has said, the audit chairs, as it's currently written, will bring that outcome discussions, the delegation back to the board. That's really important because the board remains accountable and responsible for those decisions, although we're delegating the authority to make the decisions to the joint committee. The board remains responsible. So it's really clear that we close that circle.
Yeah. Great. Okay, so we can tend to approve as recommended. On the audit committee then and the remuneration, Holly, what we just the fact is what we need to do on this Liverpool Women's, those committees.
Yeah, so both sets of terms of reference for the remuneration committees, one for Loved and one for Liverpool Women's, are included within the pack. So feeding on from that conversation about delegations, just a reminder that the remuneration committee is a reserved function of each organisation, a statutory organisation and a foundation trust, so that can't be delegated. But supporting the work of the last programme, at the request of the joint committee, we undertook a review which was supported by the company secretaries to align those terms of reference so that it enables them to meet in common. So there were 3 amendments listed in relation to the chair, the plurality of the meeting, and also just to include some narrative around enabling that committee to meet in common as part of the group. That is specific to the 5 trusts in LASP as part of the group work. And there was also an ask of the joint committee in relation to just detailing and refining what the proposed scope would be, which is also detailed within the report. So presented to the the Liverpool Women's Remuneration Committees last week and approved. So those two are here for ratification today. And then the versions for Clatterbridge, the Walton Centre and also Liverpool Heart of Chest have been to their respective joint board for approval too. We're hoping that the first Remuneration Committee in Common is held on the 14th of April.
Thank you. Ratify the terms of ratification, please. Thank you. What were the audit committee points specifically?
It was just the assurance report from the meeting that was held for women's, which I think
I'm happy to talk to it. So on behalf of the chair of the audit committee, the meeting went ahead. There was a few decisions made which are captured in the paper. I think there's a couple of key points to bring out. Firstly was that we'd previously stood down a meeting in May 2025, but we had to reinstate that because we have a number of audits outstanding for the 24-25 year. So I just wanted to make that point here. And also we agreed, sorry. On the follow-up of internal audit recommendations, there was 12 recommendations that had obtained revised deadlines, 17 out of the 23 recommendations during the reporting period, but it was also noted there were 11 open high risk, some of those that went back a number of years, and there was no new revised deadlines relating to the duty of candour audit. So considering that one of the audits that were outstanding is around the PISA process, we were concerned that how that works with the duty of candour audit. So those are the things that we're coming back to in May to have a look at. And Jenny may have some updates on those audits, but at the moment I haven't seen any of those yet.
Yeah, so just a brief update on those. So in terms of the detail of the closure, I can report at the audit committee, but we've had intelligence from MIA that they don't have any concerns over their opinion for 24-25, Jackie, but we'll confirm all that through in May.
Thank you.
Okay, that's good news. Thank you. Okay, we've received the report. The women's audit. Chris, charitable funds.
Thanks, Chair. Just a couple of bits to highlight. Quite important, the appointment of an independent chair for the charity. So alongside colleagues of women, so that'll be joint role. So in post new financial year, the completion of funds restructure, which is quite significant, from 160 funds down to 32, which is taking some significant work and engagement with colleagues, but will help us to best use funds around value and impact as a whole, opposed to holding funds across too many areas. And then in terms of expenditure, you always believe me to be rather frugal in some of this expenditure. We committed around 61,000 through 12 applications for small grants, which are £10,000 and under, £197,000 across 7 applications at grant making committee, which are 10,000 to 50,000, and then a significant investment in research projects at St Paul's, 109,000. Although the discussion was around long-term financial sustainability of charity, given our expenditure is far exceeding our income at the moment.
I say we've gone from one extreme to the other. Now we're on the charitable funds.
We have been.
Thought it was the US tariffs that were affecting it.
It's certainly impacting our investment funds levels and therefore our income levels. But there's an important shift as well around the nature and impact of where our expenditure is going. One of the examples being St Paul's Surgery, about how then we support the organisation in terms of waiting lists, income generation as well. So I think there's been that shift in terms of how we're spending our money.
Thank you. Thank you very much. Brings us to the end of our formal business. We will capture the
Chair, sorry, just before you finish, can I just make 2 simple requests to the board, one on the basis of equality and one on the basis of transparency? I have raised the issue about people not being able to hear in the meeting. And I think it's a really bad experience for our visitors who I think have found it. I found it difficult to follow a lot of the meeting. So I would actually formally ask that you purchase some microphones. I've done a count and you'd need 9 or 10 to share between two so that everyone around the table can project. It's very difficult to hear at this end of the meeting. And the second one is about the papers appearing in public. And I know staff are under extreme pressure at the end of the financial year, but to get a notification on Tuesday that a meeting has actually taken place, nothing on the public website, which are checked, and then to only get the papers yesterday. And some of us have tried to plough through 600 and odd pages. We have a life outside here, we're not paid, but also I just think that's not in the interest of their transparency, and I think something needs to be done about that.
Yeah. Both points well made and well taken. Thank you. And over to do better. We've dealt with the questions that have been notified in advance to the board. Meeting closed.